Yeah. So like, I'm like, well, I guess it's not that early for me, is it? So I shouldn't complain too much.
No, I think thanks for subscribing, guys. Keep tapping the screen. Guys, we're going to be talking about women's health, abortion issues today. Danielle is, I've said this many times in the last couple of days, and just cover your ears if you don't want to be embarrassed. But truly, since I've joined TikTok, like, one of the biggest pleasures has been to meet her and be educated by Danielle. Like, this is absolutely such a treat that she is here. So that's what I want to say right now. And I've been reading, I like to do my research before you come and just read up on what's in the news on abortion rights. And I was, obviously Amber Thurman is a big deal, and Candi Miller that ProPublica have brought to light. And I was just reading right now, which, when I need to get ready and like get motivated, I was reading like The Federalist, which is like the Federalist Society's like disgusting publication of BS, and their like rebuttal to the ProPublica article about Amber Thurman, which is just a bunch of disgusting propaganda and
Yeah.
lies. So I'm
Basically,
ready to
yeah.
go.
Gearing up my laptop over here. Got to get everything logged in.
I know. Yeah, no problem. And guys, I did put some resources last night that are in the Discord in the live sources section. Again, if you're not in the Discord and would like a link to it, just message at Felice Navidad Live and we'll get you one. But I put I put, Chrissy was nice enough. I got together about 20 articles, including the ones we were talking about last week from ProPublica about Amber Thurman's case and Candi Miller, and just some other like what's been happening in the news recently about abortion. And that is in the live sources section. So you can refer to those and look at them if you want to do extra research after this.
I do highly recommend that people read up on Amber Thurman and the Candi Miller case, because if you look at them, if you read them, if you read what was going on for both of those people in terms of their lack of care, the delay of care, the lack of access to care, I think it really, like what's kind of happening in Georgia highlights really well what's going on across the country. And they did just have hearings in Georgia last week, or maybe it was 2 weeks ago, where they heard from 3 women that were affected by Georgia's abortion ban. They came forward, they talked about how lack of access to care, how they had to leave the state to get care. And they also talked about like delays in care and not being given good information regarding their pregnancy outcomes. Doctors literally could not give them accurate information about their risk factors for that pregnancy and what the likely outcomes for those pregnancies were. So that's on YouTube. You can also listen to that. It's about an hour long, so I will fully say that it is relatively long. It is 3 people's testimonies, but they really discuss how Georgia is kind of a microcosm of what's going on in the other states and in the South. And Georgia has a 6-week abortion ban. They don't have what they call a total ban, but a 6-week ban is a total ban. You cannot access abortion at a 6-week ban, which is the same thing that Florida has as well, is a 6-week ban. So all of these things really kind of come into play, and they're told through the stories of Thurman and Miller, and then they're also told through the stories in that YouTube video. So those are absolutely wonderful things to listen to if anyone wants to kind of get like a good overview on what's going on in the South.
And then just as a resource, guys, what she's talking about, number 11 in the 20 resources I listed last night for this live and for you guys to refer after, it's like an interactive map that is updated in real time by the New York Times about abortion bans, their severity and everything in real time. That's number 11 in the outline in the live sources section. And you can refer back to that at any time as changes are made, and they show you on a map by state what the abortion bans are like, what the restrictions are like in each state.
So Felice, do you want to take questions? Do you want us to kind of do like a rundown? Do you want to talk about what's going on? How do we want to start?
Yeah, I was thinking, do you want to just give an overview of like Amber Thurman and Candi Miller and discuss that stuff? And then, yeah, definitely at the end, I think people always have a lot of questions and want to discuss. But I thought if you wanted to just get into those 2 cases, and then we can use that as a jumping off point and see where the conversation goes from there.
Yeah, so Candi Miller's case is a little less documented, if you will, because she did not, like Amber Thurman's case is pretty well documented because she was in the hospital, right? So we can see like the literal timeline kind of what happened with her. When it comes to Candi Miller's case, her case is a little less documented, like timestamp by timestamp, right? Because in Amber Thurman's case, we have timestamps on the medical record where the providers are putting in, like at 6:18, this happened, at 12:04, this happened. And in Candi Miller's case, she did not want to seek medical care because she was too afraid to seek medical care because she had taken abortion medication. So in her case, we really can't see as well and clearly laid out. And that's what happens when people are afraid to seek care. When people are afraid to seek care, we don't get a good timeline. We don't get a good story. Now, that is not at all on Candi Miller, at all. That is on the state abortion ban. She was too afraid to go to the hospital to seek care. But Candi Miller was 41 years old. So she would have had what we call advanced maternal age. There's also advanced paternal age. I always like to point that out because a lot of men like to skate over that.
Thank
and a
you.
lot of men are like, oh, right? A lot of men are just like, oh, we're attracted to youth because they can have babies. That would make sense for women too, if that were the case, because advanced paternal age, also called APA, is something that we know contributes just as much to birth defects, contributes just as much to complications in pregnancy and complications following pregnancy. So I always like to point that out. Men's sperm does degenerate as they get older, and usually advanced paternal age, it's the same thing as advanced maternal age. You'll look at different studies that will say different things. Some studies say advanced maternal age is 40 plus. The most likely one that people have heard is 35 plus. Advanced paternal age is the same. It's 35 plus or 40 plus, depending on, what study you're looking at. But what we do know is that men's sperm does tend to degenerate after the age of about 35. Your sperm just isn't as good as it used to be. Just like eggs, you have less eggs and the eggs are not as good as they used to be. So I always like to point that out because people like to be like, well, it was her. Also, sperm contributes to this too. So she was 41 years old. She found herself pregnant. She already had 3 children previously. And she had lupus, she had severe hypertension, she had what we call pre-existing conditions that exacerbate any complications that might come for pregnancy. So for people with lupus, it can be very dangerous for them to be pregnant. If you already have a hypertensive disorder, it can be very dangerous for you to become pregnant.
Can I read this one paragraph really quick on this is from this is from the ProPublica article because I think this is what stuck out to me and if anyone has dealt with an autoimmune disorder, knows someone who has, lupus is literal ongoing torment that is not well recognized. Like the pain management, often people's pleas for help with pain go ignored. We know this happens with misogynoir in medicine, particularly with Black women, right? So that's why. And so here, this is what stuck out to me, and I just highlighted it. There is no cure for lupus, but patients can manage symptoms with a mixture of drugs and therapies. 90% of those afflicted are women, and the condition is 3 times more common in Black women than white. Miller also had diabetes and hypertension. Those conditions layered on top of her lupus can be dangerously exacerbated by pregnancy and are highly unpredictable during both the pregnancy and the aftermath. Patients with those conditions are also more likely to have a pregnancy that ends in miscarriage or premature birth, and are more likely to need a cesarean section, a major surgery that is especially hard for patients with diabetes, which she also had to recover from. I just want to make sure everyone understands, this woman had lost before she started. With support, some patients can remain stable and have healthy pregnancies, though those experiences can be physically taxing and painful. In the worst cases, pregnancy with lupus can lead to high blood pressure that can quickly progress to seizures, kidney and liver dysfunction, and ultimately death. Now this is the stat I wanted to read. Studies have found the maternal death rate for women with lupus is 20-fold higher than for those without lupus. And there's a hyperlink if you want more information on that. Sorry, go ahead.
That's okay. Also, I believe the article also mentions, which this is true, if you have lupus, being pregnant puts you at a much higher risk for flare-ups. So being pregnant on its own is already high risk. It is always more risky to be pregnant than to not be pregnant. Always. Pregnancy is not a health neutral condition. And we have this bias in our society that's like, oh, women's bodies are just made for this. They're supposed to do this. So there's no way pregnancy is risky. Pregnancy is and always has been extremely risky. Always. It has always been risky. What has happened over time is we've lowered the maternal mortality. Maternal mortality is death during or within a year following pregnancy. So if you, from the time you get pregnant to a year postpartum, so a year after you have that baby, that is what we count as maternal mortality, because even after you have the baby, you are still at high risk. In the US, you're particularly at higher risk because we have a lack of access to good health care. We have a lack of access to prenatal care. We have a lack of access to, excuse me, I was getting a phone call. That might happen a lot, y'all. It is Tuesday morning. It's my clinical day, so I'm probably going to get a couple phone calls here and there. But we have a lack of risk to postpartum care, or sorry, a lack of access to postpartum care. And then the other thing that we have in the US that really heavily contributes to maternal mortality rates is we don't have paid parental leave. So we do know that there are kind of various points postpartum that it is extremely risky for you to go back to work. One of those is 2 weeks. If you go back to work within 2 weeks of postpartum, you're extremely high risk for hypertensive issues, for bleeding issues, potentially for sepsis, depending on what your birth looked like. And then if you go back to work before 6 weeks, you're at even more, you're at another risk level, right? So 2 weeks is very risky, 6 weeks is very risky. After that, we kind of start to see the risk go down. But a full, I think it's like 25% of people in the US go back to work within 2 weeks after having a baby because they can't not work. They need the money, right? So that puts people at higher risk. When we talk about maternal mortality going up for people of color, Black women in the US are 2.5 to 3 times more likely to die in childbirth or postpartum, so that maternal mortality range. And both of these deaths, both Amber Thurman and Candi Miller, were both Black women. And then we also had, and this one did not hit the news very heavily, if you will, but Yenny Alvarez died in Texas in 2022 as well. I might argue that she was one of the first people to die after the Texas abortion ban. And she was very similar to Candi Miller. She was pregnant. It was a very wanted pregnancy. However, she had, I believe it was pulmonary edema, which is fluid in your, like around and in your lungs. So that put her at very, very high risk. As she kept continuing with the pregnancy, her risk went up, to the point that doctors knew for a fact that continuing this pregnancy was going to put her life at risk. At that time, she was only like 14, 13 weeks pregnant, something like that, well outside the limits of any abortion ban in Texas. Abortion is banned in Texas. And the life-threatening exceptions, first of all, exceptions in abortion bans are never meant to actually be used. They're vague on purpose. They're not actually meant to be able to be put in use. They're put in there to like placate people, but they're not actually usable. Even so, those exceptions for life-threatening circumstances usually don't cover chronic health conditions. They only cover things like you're septic or PPROM, which is preterm premature rupture of membranes. So
I was just reading that in this. I was just reading about this. It's terrible. Yeah, not chronic, just acute.
Which is exactly what happened to Candi Miller. She had chronic health conditions, but chronic health conditions do not qualify for a medical exception to receive an abortion in Georgia. So she didn't have any option to receive care in Georgia. So she got abortion pills. She took abortion pills at home, extremely safe. I always like to remind people that Viagra and penicillin have higher risks than abortion medication. taking
Thank you.
Viagra or taking penicillin. Go ahead, but
I was just, yeah, no, I was just going to ask you to speak to like how safe the abortion pill is. Because when I'm reading, because I was looking for, you know what I was saying? The Federalist Society is releasing a bunch of articles and literature kind of saying, oh, ProPublica is misleading people about Candi Miller's case or misleading people about Amber Thurman's case. And they're saying they died because the abortion pill is not safe. So if you could speak to that, like the safety of the abortion pill, I think everyone would like to hear that.
Yeah, so our maternal mortality rate in the US, we just came out with a new number in 2022. So people also like to ask me, like, why do we have 2022 numbers? Why don't we have 2023? We lag about 2 years behind in reporting those numbers because we have to wait for the year to end, right? We have to wait for 2022 to end. And then in 2023, you go through all of that data. Each state has a maternal mortality committee or an MMC that reviews all of those deaths. So they look through the deaths and they say, yes, this one counts. Yes, this one counts. Yes, this one counts. Every once in a while, there's one that's added in there that doesn't count. Like it was checked on the death certificate or something like that. Maybe somebody died in a car accident and it really wasn't related to pregnancy or childbirth. Those ones get thrown out, right? So they review all the cases. They determine which ones still count, if any of them need to be thrown out. And then the ones that need to be thrown out, they throw the ones that need to be thrown out, and the ones that are kept, they review those ones to determine how likely is it that this was preventable. And we know that an extremely high percentage, somewhere between 70 and 80% of maternal deaths in the US are completely preventable. Both Candi and Amber's deaths were completely preventable. Yenny's death, completely preventable. However, in Yenny's case, she was never offered abortion care. That was never given to her as an option. Her doctors just kind of kept like getting her through longer and longer, further and further in the pregnancy. And she ended up dying. She literally ended up essentially suffocating because her lungs couldn't take it anymore. And again, this was a wanted pregnancy. She was married. Republicans love to have like the perfect victim, right? Amber Thurman, Candi Miller, not perfect victims, which is why we're going to see the Federalist attacking them, right? First of all, they're women of color. The perfect victim is Kate Cox. She was the perfect victim for them, right? She's a conventionally attractive, blonde, white woman, a Christian. She and her husband weren't exactly pro-abortion before this happened, right? And now this thing happened and it totally changed her stance. It was a very, very wanted pregnancy. They wanted to be pregnant. She is, in theory, the perfect victim. And yet still, Republicans look at her and say, no, she doesn't count. She took a case to Texas Supreme Court and said, I wasn't able to get the care, her and over 20 other women, and asked for the Texas abortion ban to have clarifications because all of these 20 plus women, I think it was 23 by the time it was done, said we were not able to access abortion care in the way that we needed to because the exceptions are too vague. Doctors cannot act on them. And Texas looked at it and said, no, we think you're just fine. We think it's fine. We don't need to correct anything. We don't need to clarify everything. Everything is fine, right? So when we talk about like, you're going to see people in the comments and all that stuff say, well, they took abortion pills. They took abortion pills. Does that mean they deserve care less? Does that mean that they deserve to die? Do you need them to be the perfect victim in order for them to get care? Do you think that because somebody took an abortion pill and then showed up at the hospital and said, I'm dying, that you should look at them as a healthcare provider and be able to say, you actually deserve this because you took the abortion pill? Think that through for a second. Think about how asinine that sounds, how ridiculous that sounds. What if that was your sister? What if that was your mother, right? It's sad that we have to do that. It's sad that I have to relate that to people. Like, you should care. I shouldn't have to teach you how to care about people. That should be basic in you. But because it's not, right? What if that was somebody that you loved and they showed up to the ER and you drove them there, and now clinicians are standing there going, well, you took the abortion pill, so you kind of deserve to die. Like, that's
I
ridiculous.
went over Amber Thurman's case, yeah, and we literally had Joel Patrick, who has 3.1 million followers. I'm taking him through Amber Thurman's case, and he literally said word for word, well, any woman who seeks abortion care, she deserved it then.
which is how Republicans feel, right? Like if people think that these deaths were not known and planned for, they were. The Republican Party, in making these bans, 100% knew that women were going to die. They didn't care. They didn't care. And you know they didn't care because they hire experts to come in and talk to them about this stuff. They have experts testify, and they don't care. It's not like they're sitting there going, oh, this won't happen. Some of them are, right? But they knew that deaths were going to happen. And they already had pre-planned to spin it in this way that like, well, they kind of deserved it. Oh, well, she wasn't the perfect woman, right? Which that's exactly what misogyny is, right? If you're not a good, perfect woman, if you don't fit into this box, then you get what you deserve. We were talking about, now I kind of got off on a tangent. So let's go back to Amber Thurman and Candi Miller's case. Someone mentioned in the comments, Candi Miller also had diabetes. That is true. So she had a multitude of pre-existing conditions that made this pregnancy much, much more high risk. In addition to the fact that she was 41 years old, if she were able to actually use a medical exception due to a life-threatening circumstance, this would have counted because her doctors blatantly told her a pregnancy can kill you. It's very likely that a pregnancy will kill you. Your body cannot sustain a pregnancy healthily, right? She took the abortion medication. She has a 3-year-old. She has 3 previous children, right? A 3-year-old, a teenager, and I'm not sure how old the other one is. Her teenage son watched her dying in bed, listened to her crying, listened to her moaning, listened to her being in pain. And then her husband came in and found her laying next to their 3-year-old, completely unresponsive. Her 3-year-old was there in bed with her, and he found her dead. That's horrific. And that is what Republicans want, right? Because you deserve this for not being a good woman. This is somebody that was married, had 3 previous children, and it's not like this pregnancy was like necessarily horrifically unwanted, right? There's nothing in the story that says like, oh, she definitely didn't want any more kids, da-da-da. Like she didn't want to be pregnant because it was high risk for her. So if pregnancy is high risk for you, a lot of times, depending on how high this risk is, right? You don't have the privilege and the option of sitting back and being like, do I want to have another baby? You can't without risking your life. Now, I'm not going to judge somebody that says, look, I really, really want a baby and I'm okay with taking that risk. That's fine because that's what consent is about, right? Consent means I have fully informed you of your risks, you fully understand them, and you choose to go forward anyway. And again, bodily autonomy, you get to do what you want with your body. You get to choose what risks to take with your body. So I'm not going to judge anybody for deciding that that risk is worth it for them. But for Candi, that risk was not worth it. And she deserved to be able to make that choice. I don't want to risk dying in order to carry another pregnancy to term at 41 years old when I already have 3 other beautiful children. It's more important for me to stay here for these children that I already have with my husband and not leave him to be a single father. And that choice was taken from her. She tried to regain that choice by taking abortion medication, right? Amber Thurman did something somewhat similar. Before I talk about her, I'm going to talk about abortion medication. Abortion medication, the rate of death for abortion medication is about 0.4. 0.4, not even 1, 0.4. That is not 0.4%. So I have to be really careful because some people will be like, wait, percent. It's not 0.4%. That's a rate per 100,000, right? So we do a rate is 1 per 100,000, right? So 0.4. Our maternal mortality numbers in this country right now, I think it's like 21.9. I'm going to look up the 2022 numbers. It used to be 32.9. That's a number that a lot of people know. That was our 2021 rate. That rate was so high, we think because of COVID. 22.3 is our current rate. To put that in perspective for other people, 22.3, remember that is not a percentage. That's 22.3 per 100,000. If we want to put that in perspective, places like New Zealand, England, France, their rates are like 8, 7, 6, 7.2. Ours are absolutely abysmal. We have the highest maternal mortality rate by more than double of any other high income country. If you can hear my dog snoring, I apologize. He's doing something, he's doing the most back here. So those rates already extremely high. People look at that and they're like, oh, 22.3, like that's not super high. It's horrifically high, horrifically high. But which number is bigger? Poll for the comments. 0.4 or 22.3? 22.3. That's obviously really high, right? So abortion medication, extremely safe. And the other thing is, if a complication comes up from an abortion medication, it's usually either bleeding, like you're bleeding really heavily and that's kind of become a problem, or sepsis. Both of these women died from sepsis. Both of them. Yenny did not die from sepsis. That was a different story. She died from her pre-existing conditions. The pregnancy literally exacerbated her pre-existing conditions so much that it killed her. That's not horribly uncommon in pregnancy, especially if you have a lung or a heart problem. Pregnancy puts a ton of stress on your lungs and your heart, a ton of stress. You have a massively increased blood volume, massively increased blood volume. Your heart has to pump so much more, so much harder. If anyone in the comments has ever been pregnant, tell me you know like that huffing and puffing feeling, right? Like you're pregnant, you're trying to walk or you're trying to go upstairs and you're like, whew, whew. Like you're carrying a lot of extra weight and your heart is doing a lot of extra work. That makes pregnancy really dangerous for people that have heart or lung issues, right? I see all the people in the comments are like, yep, been there, right? Because it's freaking tiring to move that body around when you've grown another human being. So when we look at abortion medication, we see, and I saw someone in the comments say Tylenol as well. Tylenol has a higher risk factor than abortion medication. But because that's an over-the-counter medication, a lot of people look at that and they're like, well, that's because people have more access to it and they have access to as much of it as they want, right? Okay, fine, I can give you that. But still, penicillin, one of the most commonly used antibiotics. I'm willing to bet that a large majority of people in the comment section have used penicillin at some point in their life, has a higher risk factor than abortion medication. Viagra, higher risk factor than abortion medication. And we're still like handing that stuff out as if it's candy, right? So abortion medication, extremely, extremely safe. If for some reason you have a complication, easily taken care of. If you have a complication where you have what we call retained products of conception, which means that you did not expel all the fetal tissue after taking the medication, the answer to that is a DNC. It's a 15 to 20 minute procedure, super easy. It is an outpatient procedure. You would go into the hospital, have it done, and you're out again that same day. You're gonna go home, have some cramping, some bleeding. Everybody responds to it a little bit differently. It also depends on how far along in the pregnancy you are. Obviously, the further along you are, the more cramping, the more bleeding you may have afterwards, right? But it is an extremely easy complication to treat. Those complications are extremely rare. But if they happen, they're very, very easy to treat with a DNC. If you have bleeding, you go into the hospital, very, very easy to treat. For some people that are taking abortion medication, it's kind of hard to tell how much bleeding is too much bleeding. There's an abortion hotline that is there to help you with that kind of stuff. If you've taken the abortion pill, there's an abortion hotline that will kind of walk you through that. A nurse will be on the phone or a worker will be on the phone and say like, okay, it's probably time for you to go to the doctor and get checked out or something, right? But again, all the complications are extremely easy to rectify if you feel okay going to the hospital and getting care for it. But in Georgia, neither one of these people felt super safe going to the hospital to get care. Amber did go to the hospital to get care. Candi didn't. Their outcomes were exactly the same.
Yeah, and in Candi Miller's family, it says that Candi Miller believed truly. This is right after the Dobbs decision and the Georgia 6-week ban goes into effect, where politicians were publicly saying, if you seek an abortion in Georgia, you need to be prepared to have legal consequences. Candi Miller fully believed if she went to the hospital, she was going to, she would be committing a crime.
And that is not horribly unheard of, right? Because we know that the people that are being criminalized for either self-managing their abortion or being criminalized for their miscarriage, right? Being criminalized for the outcome of their pregnancy, those are almost exclusively women of color. I cannot, off the top of my head, think of a white woman that has been charged. Not saying it hasn't happened. I'm just saying the stories off the top of my head are all women of color that have been charged. We had a woman, I want to say it was in Alabama. This was before the abortion ban even took effect in Alabama. This is before the abortion ban. She was leaving a dollar store. Oh, Marsha Johnson. Her name's Marsha Johnson. If anyone wants to look it up, it just came to me. I want to say Alabama, but Felice is going to let me know in a second. She was leaving a store and someone got into an altercation with her. They pew-pewed her and the fetus died. And she was charged for that. Not the person with the pew-pew, not the person that pew-pewed her. She was charged because the prosecutor said she shouldn't have put herself in that position, that she chose to put herself in that altercation position. And for that, she was liable.
Alabama.
Of course, it's Alabama. Y'all, it's always Alabama. I know.
Eternal desert.
Except we did have the one in Idaho recently. Or not Idaho, Ohio. It was Ohio. We had the one in Ohio recently. At least I can't remember her name. If you can find it, great. She was a Black woman. She got charged because of her miscarriage. She got charged because of she went home. She had a miscarriage at home because, you can't help people with a miscarriage anymore. You can't give people miscarriage care. She went home. She had a miscarriage in the toilet, which is often where people have a miscarriage, right? You're bleeding profusely. You can't use a tampon if you're having a miscarriage, y'all. You don't want anything up there. It will increase your risk for infection. If you are having a miscarriage, please do not use tampons. Use an adult diaper. I know it's not sexy. I get it, but this is for a shortened period of time. Or use a pad, right? Or a lot of people, when they're cramping and all of that, they sit on the toilet. The name from Alabama is Marsha Johnson. Someone just asked what's the name.
Yeah, and this is Brittany Watts. This is Brittany Watts in Warren, Ohio. And I'll put this article about this. I put an article about Marsha in the Discord in the general chat, and I'll put one right now about Brittany Watts.
So Brittany Watts, she went home, she had a miscarriage on the toilet, and she flushed. Okay, that's what a lot of people do, right? Like, you're not exactly having a miscarriage and sitting there and picking through it, y'all. That is not how this works. You sit on the toilet, you expel, you cramp, right? You're literally, y'all, miscarriages are painful, horrible. You should see a woman, everyone should have to sit in the ER and see a woman coming in with a miscarriage. We're talking like, have you had a kidney stone? If anyone's had a kidney stone and you ever see someone with a kidney stone, they can't sit still, right? They're like moving. They're like, oh my God, I can't sit still. It hurts so bad. This is what a miscarriage feels like. You are cramping so badly and you're bleeding, you're sweating, right? You're so uncomfortable. For some people, it feels just like labor pains. People that have had labor pains and also had a miscarriage say like, yep, they feel pretty similar, right? And we're not helping these people. We're sending them home and saying like, we can't help you because we don't want to have to be charged with giving you an abortion. DNC procedures have been criminalized, so we can't give you a DNC. You're just going to have to go home. So she goes home. She has the miscarriage on the toilet. She flushes it. It clogs the toilet. She ends up getting charged with, Felice, you'll have to tell me, I think it was like abuse of a corpse, or not properly disposing of a corpse or something like that, not properly burying a corpse. So you aren't going to necessarily be charged under the state's abortion ban. They don't need the state's abortion ban to charge you. They don't need
abuse of a corpse, yeah.
Abuse of a corpse. And someone saying, what was her alternative? Nothing. She didn't have an alternative, which if you look at like Students for Life, which is one of our biggest anti-abortion organizations in the US right now, what they would rather have women do if they're having a miscarriage or they've taken the abortion pill, they want to require women. Have you seen those, like, I can't think of what they're called now. We call them hats, but that's not literally what they're called. They're little bowls that you set in the toilet. If anyone's ever seen them in the hospital, they like sit in the toilet.
In hospitals, yeah.
Yeah, again, we call them hats, but that's not their literal name. I just know them by like what we call them. But you like if you had a kidney stone, we usually have you pee into one so that way we can like see where your kidney stone came from, right? Or if we're measuring your urine in the hospital, you pee into one so we can see how much you're peeing in it. Someone said a bedpan. It's kind of like it's basically a bedpan that sits in the toilet, so you can sit on the
It has
toilet,
like lips on the
pee into
side,
it.
so it
Sits there, right? They want you to have your entire miscarriage into that and then bag it in a hazard bag and then take it to the hospital for disposal. That's what they would rather have you do. So people are like, what was she supposed to do? Anti-abortion people want you to have to collect all the contents of your miscarriage in a bowl, put it in a biohazard bag, and then take it to the hospital. That's horrendous. That's horrendous. You're already going through one of the most difficult things that a lot of people have to go through, both physically, because it's so painful, but also mentally and emotionally, right? And now they want you to have to bag all of that up and drive it to the hospital, sitting in your little passenger seat next to you.
as evidence to prove that you didn't flush. Like it's and any woman in here who's had a painful miscarriage, especially like not an early one. I mean, how do you even do that? Like, I just can't believe this is where we're at.
It's insanity. So I'm looking up the Amber case, or I'm pulling up my notes on it because I have whole notes on it, y'all. I've had to lecture on this a couple times, and I have ADHD, so that usually means that I don't know where my notes are stored. Here we go. Got it. So let's walk through the Amber Thurman case because I think it's a really important case to take a look at, because as you go through the case, there are multiple points where care should have been initiated. And this is what we mean when we say a delay in care causes life, right? That causes people to lose their life. She did end up getting care. She got it too late. So let's look at her case. So Amber goes to what happened with her is she found out she was pregnant with twins. She already has a child. She was going to start nursing school. She wasn't ready for another pregnancy. You can't get an abortion in Georgia, so she made an appointment in North Carolina. She made an appointment for a D&C procedure. But because of traffic and all of that stuff, she left at 4 o'clock in the morning. She left at 4 a.m. to make the drive from Georgia to North Carolina. In theory, plenty of time. But they hit traffic. She called the clinic and said, hey, we're hitting traffic. Our map ETA says that we're not going to make it in time for my appointment. Can we push back the appointment? Do you have another appointment? Because they're so overloaded with appointments, they couldn't give her another appointment that day. But she already had to take off work. She already had to find a babysitter, and she had her best friend drive her, right? We're talking about an hours-long drive. So she couldn't reschedule this appointment. There was absolutely no way. So the clinic offered her the best second option they had, which was to take abortion medication. She was well within the window for abortion medication to be effective. However, if you're pregnant with multiples, that does slightly increase your risk. That doesn't mean that you can't take abortion medication. We give it to people all the time that have been pregnant with multiples and they're having a miscarriage to help them expel all the contents of the uterus. So it was well within standard of care. She was well within the time frame. They gave her the abortion. She took the first pill there. The abortion pill is actually a series of 2 pills, right? Misoprostol and mifepristone. So she took the first pill there in the clinic, went back to Georgia, took the second pills at home. It's usually a series of 4 pills, but it kind of varies depending on how far along you are in pregnancy. So she goes home. She takes the second series of pills, which is what she was instructed to do. It's what we instruct people to do. She takes the second series. She starts bleeding and all of that stuff. But over time, she starts to feel really sick, right? Her blood pressure is getting dangerously low. She's bleeding a lot. She passed out at home. So she goes to the ER. She arrives at the hospital on August 18th. This is 2022. She arrives at the hospital on August 18th at 6:51 p.m. On examination, so per her medical record, this is all per her actual medical record. On examination, she showed tenderness in her lower abdominal area, a high white blood cell count, and a dangerously low blood pressure. All of those are indicative of an infection. That is immediately indicative of sepsis to me, right? At a minimum, you've got an infection. Maybe you haven't gone septic yet, right? But I'm worried. I'm seriously worried. It is clear what is happening from this first entry. So let's make that crystal clear here. It's clear what's happening from this first entry. She was honest with providers. She said, I went to North Carolina. I got abortion pills. I took abortion pills, right? Technically, she can't be charged under the state's abortion ban because it says that we're not going to charge women. Georgia does, though. So she was also soaking through more than a pad an hour of blood, which probably had something to do with why her blood pressure was dangerously low. That's a lot of blood, y'all. A pad an hour is a lot of blood. And upon a pelvic exam, doctors noted a foul odor coming from the pelvic exam. Foul odors are indicative of infection, right? So again, immediately clear that she had an infection. She should have had a DNC at that time, but she didn't. So they did almost nothing until 10 p.m. So remember, she arrives at the hospital 6:51. We're 3 hours later now. At around 10 p.m., just before 10 p.m., they start her on IV antibiotics and fluids. IV antibiotics are great, but if you don't take care of the source of the infection, you're just putting a Band-Aid over a bullet wound, right? We need to take care of the source of the infection, which is in the uterus. They're giving her fluids to try to bring her blood pressure back up. Your blood pressure is essentially how much pressure is being emitted on your arteries when your heart pumps, right? Your arteries and your veins, but let's just keep it simple. So how much pressure is being emitted on that? If you have a low blood pressure, one of the reasons you might have a low blood pressure is because you don't have enough blood volume. If you don't have enough blood, you're not going to have a high blood pressure. So the low blood pressure is indicative of how much blood she is losing, right? And someone is saying in the comments that this pregnancy was not viable. You're right. There was no heartbeat. This pregnancy was not viable. Also, you're going to hear planes flying overhead. They're evacuating planes because we're going to get a hurricane this week. If anyone's in Florida with me, buckle down because I think Helene is coming. So at 10 p.m., IV antibiotics and fluids, right? That doesn't really do a whole lot. The next morning at 5:14 a.m., an OBGYN officially diagnosed her with acute severe sepsis. So she gets in at 6:51 p.m., almost 12 hours later, right? We're looking at like really 10 hours later, 10, 11 hours later. They diagnosed her with acute severe sepsis. All they did was increase antibiotics and fluids. That's it. Increase antibiotics and fluids. They gave her 5 liters of fluid. Think about how much that is. We've all seen those 2-liter bottles of soda, right? That's 2.5 of those of fluid that they pumped into her. That is a ton of fluid. Again, we're trying to get that blood volume up. We're trying to get that blood pressure up. That's a ton of fluid. After 5 liters of fluid, she had no change in her blood pressure at all. So they started her on a medication called Levophed. Levophed is what we call a vasopressor, right? It is the opposite of a blood pressure medication. A blood pressure medication brings that blood pressure down. A vasopressor brings that blood pressure up. The fact that they gave her Levophed says to me that she had a life-threateningly low blood pressure. You only give Levophed if someone is in a life-threatening situation, because one of the major complications of Levophed is needing an amputation. Literally needing an amputation of your fingers, of your hand, of your toes, because think about what is most distal from your body, what is furthest away from your heart. Those are going to have, first of all, they're going to have smaller capillaries, right? You have smaller capillaries as you get into your smaller little appendages, but it's far away from your heart. Those are the things that if we give you a vasopressor, which constricts your blood vessels to try to get your blood pressure up so you don't die. If we constrict blood vessels, the blood vessels in your fingers and toes are going to constrict too. And if they don't get enough blood, they're going to turn necrotic and we're going to have to amputate them. So the fact that they give Levophed meant that they thought it would be more beneficial to her and the risk of amputation was worth it. right? So we start Levophed. This is going to become really important later, really important. So remember this vasopressor. Then I'm kind of scrolling through my notes. I don't want to give you guys anything that's not really necessary. At 6:45 a.m., right? So we start Levophed at 5:14 a.m. Now we're at 6:45 a.m. At 6:45 a.m., she's moved to the ICU, the intensive care unit, right? So at 6:45 a.m., she's moved to the ICU because she has deteriorated so badly and her blood pressure is so low that she needed intensive care. They kept her in the hospital, continued to give her medication. At 7:14 a.m., the internist and the ICU doctor write a note saying that OB should initiate a DNC. So we're at 6:45 a.m. We are now a full 12 hours after she has been in the hospital. 7:14 a.m. is when they say initiate a DNC. 2 hours later, labs showed that her organs were failing. At 12:05 p.m., the ICU doctor paged OB and said she's going to need a DNC or she's going to die. It takes them an additional 2 hours to get her to the OR. She doesn't go to the OR until around 2 p.m. By then, the situation was so bad. A DNC, y'all, if anyone doesn't know what that is, it's usually done vaginally. So it's done through the vaginal canal. If you've ever had a pap smear, kind of similar idea, right? You're up in stirrups, go in through the vagina, clean everything out, clean out the source of infection. You're still going to have to be in the hospital. You're still probably going to have to be in the ICU and on antibiotics, depending on how bad your sepsis is, right? But that is usually, again, about a 20-minute procedure, clean everything out, good to go. When they get her in the OR, they realize that the infection has gotten so bad that they have to start with open abdominal surgery. So now they have to cut her open, split her open her up to get some of that infection out. When they open her up, they found that her bowel was necrotic and it needed to be removed because the infection had gotten in there. But it was too risky to operate to remove her bowel. Why? There wasn't enough blood flow. Yeah. Why wasn't there enough blood flow? Because we gave you a vasopressor and you didn't have high enough blood pressure. Right? Now, it is kind of hard to say it was 100% due to the vasopressor, right? It was likely due to a combination of having low blood pressure and also giving a vasopressor, which constricts those blood vessels, right? But her bowel was necrotic and needed to be removed. However, at this time, they decide to initiate the DNC. The OB begins the DNC and then realizes that she has to do a complete hysterectomy, because the uterus is so infected that there is no way to save it. Remember, at 7 p.m. last night, we could have done a DNC and all of this would have been avoided, completely avoided with a 20-minute procedure. Now we're in the OR. We have someone whose abdomen is completely cut open, opened up, infection all over inside the abdominal cavity. Bowel needs to be removed, but can't be. OB initiates the DNC, can't just do a DNC, has to remove the entire uterus because it's infected. And while she is attempting to do the hysterectomy, Amber's heart stops on the table and they can't get her back. If your blood pressure gets too low, if you've ever seen like movies or something like that where people bleed out, or car accidents or something like that where people bleed out, your heart can't pump without blood. The lower your blood pressure, the higher likelihood of your heart stopping. And when you take somebody into surgery and they already have a low blood pressure and you're cutting them open and they're losing blood, this becomes an extremely, extremely high-risk scenario. She died on the table and they couldn't get her back. The last thing she said to her mother as they were wheeling her away to surgery was, "Make sure someone takes care of my son." This is horrific. Son. Her 6-year-old son, who now doesn't have a mother, right? He's now left without a mother because we didn't initiate care fast enough. They did initiate care, right? They initiated care. It took them 20 hours, right, to initiate care. That's a 20-hour, that's not even a full day. Delaying care by 20 hours killed this woman. And I want everybody to also know that if she came into the hospital and she hadn't said that she took abortion medication, if she never said that, you can't tell. as a provider, the person that did her pelvic exam, you cannot tell if this is a spontaneous miscarriage or what we call a spontaneous abortion, or if someone took abortion medication. The only way that you can tell, the only way, and this becomes really important for anybody that might take abortion medication in the future, wink, the only way that we can tell is there's two ways that you can take that second medication. You can either take it, you put it in your cheeks, right? And you wait for it to dissolve mostly, and then you swallow the rest of it. Or you can do it what we call transvaginally. So you can put it into the vagina. If you put the medication into the vagina, sometimes you can see pieces of the pills on a pelvic exam. So we call it like the duck, but it's the speculum. When you put the speculum in and you open up the vagina, right, and you can see into the vagina, sometimes you can see little specks and pieces of the pills left over. That's the only way we can tell. If you take the medication through your mouth, if you take it orally, put it between your cheeks and take it orally, you cannot tell the difference between a spontaneous abortion and one that was initiated by the person through abortion pills. So all these people saying like, well, she died because of the abortion pill, she deserved it. There is no difference. There is no difference. She died because of retained products of conception, which will happen with a miscarriage or can happen with an abortion pill, either way. So the abortion pill really doesn't have any indication in this as causing this death or having anything to do with this death. Because if you're having a miscarriage and we're afraid that you might retain products, we give you the abortion pill. That is a treatment for miscarriage. It is literally the standard of care. You can have a D&C. Some people choose not to. You can go home and try to pass it on your own by yourself. Some people are too afraid of that, or they say like, I don't just want to wait around. Right? I already know I'm having a miscarriage, or I already know that this pregnancy is not viable. Sometimes people go in, they have a scan, the fetus or the embryo hasn't grown as much as we want it to, right? So maybe you go in for your 12-week appointment and it's still measuring at like 9 or 10 weeks and it's not growing and there's nothing happening, right? That's no longer a viable pregnancy. So people can choose to go home and wait for the miscarriage to initiate itself, but some people want a little bit more control. Some people find this out on a Thursday and they say, give me the medication. I'm going to take Friday off. I'm going to go home. I'm going to sit with my husband. We're going to do this together and just get it over with. Great.
Because it's psychological torture as well, in my opinion.
100%. And some people just want more control of their body, more control of their healthcare. They don't want to just wait around. And the other thing is, if you just wait around, where is that bleeding going to initiate? Are you going to be walking around the grocery store and then all of a sudden you're like, oh, right? Are you going to be sitting at work at your desk and then all of a sudden you're like gushing blood? You want a little bit more control over how this happens, when this happens, right? That gives people a peace of mind. Some people 100% choose to have a D&C, and that's totally fine too. But this is a medication that we give people for treatment of miscarriage. So if you think that this happened because of the abortion medication, and it's never going to happen to anybody that you care about because they wouldn't dare be one of those disgusting women that have an abortion, you are dead wrong. We see this all the time in miscarriages that are initiated spontaneously and you don't fully expel the contents of the uterus. You can only wait so long before that becomes a serious sepsis risk. And we know that it happens relatively frequently.
Can you explain the onset of sepsis and how serious it is? Because I do feel like there's a big disconnect, like, you know, with people and like, okay, sepsis, like, who cares? Or like, even for her to survive, like, I know my dad had sepsis in his hand once, I remember, and like how fast the onset, how fast it was spreading, like how fast they were like, we're gonna have to take off his arm, you know, like that's what it comes to, and it happens fast. She was for 20 hours in torment.
So I'm just looking at the recent stats on sepsis for everybody. So sepsis is essentially a systemic infection, right? A really common way that people get sepsis that like kind of isn't talked about very often is like teeth, right? If you have an infection in your tooth or you have like a tooth abscess, My dad had a tooth abscess when I was a young kid. He let it go, like didn't want to go to the dentist because he had to go to work that day. So he went to work that day, went to the dentist that evening, and the dentist is like, you're going to the ICU now because this is serious, right? My dad had to be in the ICU for 3 days on IV antibiotics. Sepsis is no joke. Sepsis is always 100% of the time life-threatening. 100% of the time life-threatening. So the stats on sepsis, 7 to 8% of people with sepsis will die. That is that's not a rate, guys. That's not 7 to 8 per 100,000. That is 7 to 8% of people who get sepsis will not survive that sepsis. That's an extremely high number. However, 20 to 40% of people that have organ dysfunction, which she had, will die. So she already had organ dysfunction because of the sepsis. Had she come in and they knew that she had an infection in the uterus and they cleaned it out, we wouldn't have hit that moment of organ dysfunction. But remember, her lab showed that her organs were failing. So we already had organ dysfunction. So 20 to 40% of organ dysfunction, if you get organ dysfunction, that's what your mortality rate increases from. It goes from 77 to 8% to 20 to 40%. If septic shock occurs, which is a severe complication of sepsis, if you let it go long enough, your mortality rate bumps up to 60%. 60% of people. That's extremely high. Sepsis is no joke. And that is only the people that will die from it. If you have sepsis and you have organ dysfunction with it, you are probably going to come out of this with organ damage. It's not like we get you better, we give you antibiotics, and then you get better, and then you're like, I'm good to go. People still have severe kidney dysfunction, liver dysfunction. People have a lot of organ damage that comes from sepsis because it moved from your uterus to your system. It affects your systems. What's in your body systems? Organs that are going to be damaged by this sepsis. Sepsis is one of the top 3 leading causes of death for maternal mortality.
And when they said her bowels were necrotic, that means dead flesh, right? Necro, that's the Latin prefix for dead. They're saying it had spread and her bowels were now dead flesh.
Yes. So necrotic means that like that tissue has died. If anyone's ever seen like black tissue, like a finger or something like that that's turned black, that's necrotic tissue. We don't want that to spread. We don't want that to get anywhere else. But it did, right? It spread to her bowels, which were infected. So you have to remove that infected tissue. You have to. Otherwise, it's not good, right? It's just going to keep going. So the doctors in this case, the other thing that I think a lot of anti-choice people will say, like, oh, well, it's the doctor's fault. It's the doctor's fault. I often hear people talk about the Hippocratic Oath. Why don't doctors care about the Hippocratic Oath? That is not legally binding. The Hippocratic Oath does not play into law. The Hippocratic Oath is an ethical standard, right? It's ethics. But what do you do when the law directly contradicts the medical ethics that you are sworn to? Well, if you act on it, you're going to lose your license or potentially go to jail. Someone down below is talking about EMTALA, tried to take that to the Supreme Court, right? We tried to take it to the Supreme Court saying that doctors should be able to act under EMTALA, and the Supreme Court declined to hear that case. So they absolutely could have ruled like, yes, EMTALA stands, abortion care falls under EMTALA. What anti-choice states are saying is that abortion is never healthcare. Abortion is never needed to save the life, right? So therefore, it does not follow under EMTALA. Until somebody takes that to court and wins, we're not winning with EMTALA. You can try to get it, right? You can try to claim, you can sit there in the ER and say, what about EMTALA? What about EMTALA? That's not necessarily going to make them act, right? And you don't have time to get a lawyer. You don't have time to take this to court. You need them to go, right?
You explain what EMTALA is for people who don't know.
Yeah.
Thanks.
So EMTALA is, if anyone's ever been to the ER, if you've ever gone to the ER, there's a sign usually that's hanging in the ER that says EMTALA. These are your EMTALA rights. EMTALA stands for the Emergency Medical Treatment and Labor Act. It doesn't only apply to pregnant people. What it means is if you get in a horrible car accident and this is a medical emergency and they bring you to that hospital, if the hospital accepts federal dollars for Medicaid or Medicare, you cannot deny somebody care based on their inability to pay, based on the fact that they're not a resident of that state, based on the fact that they don't have insurance. You have to treat and stabilize the emergency medical condition. Once you stabilize or treat the emergency medical condition, you can, as long as you can safely do it, transfer them to another facility, which is what we're seeing Idaho do. Idaho is currently life-flighting women over to Washington so that way they don't have to give abortion care because Idaho's ban does not allow for any exceptions, really. So rather than doctors sitting here and watching people slowly die in front of them, they're life-flighting them to Washington so they can get care over state lines. They believe that that is following under EMTALA, and technically it is because they stabilize the person enough to put them in a helicopter and get them life-flighted over. That's still an extremely risky thing because once you go into a helicopter and you're being flown somewhere, you no longer have all the medical capabilities and access of a major medical system or a hospital. You have the medical abilities of a helicopter. That's it. So if something really bad happens in that helicopter, if you tank or your blood pressure tanks or you stop breathing, you only have the medical ability of a helicopter to help that person. So that's already risky, but doctors in Idaho are looking at it and going, that's a better risk than leaving them here in Idaho. And that says something. And if anybody has never, like most people haven't taken a life flight helicopter, y'all, they are not cheap. They are charged per mile, right? Like you get additional charges per mile. So depending on how far you're flying or where you're flying from Idaho, it's going to be more expensive, but you have to foot that bill. You and your medical insurance are on the hook for that entire life flight bill. $30,000, $40,000 or more, depending on what kind of care you need in that life flight and depending on how far you're going, right? And look, we love life flight people. They're amazing. They save lives every day. They are some of the absolute best nurses and care providers that you have ever seen because they are doing emergency care in an emergency situation in a frickin' helicopter. But they are not miracle workers. They cannot save you if you don't have enough blood to pump your heart. Right? So we've gotten to the point that in trying to act under EMTALA, we're now life flighting people in helicopters across state lines. Could they have done that in Georgia? I don't know. This hospital may not have had a life flight ambulance. Not all hospitals do. You often have to be transferred to a hospital that has one. Sometimes they can be far away. This is a friendly reminder as well that maternal health deserts are getting bigger and bigger and bigger because of abortion bans. We now have about 33%, a full 1/3, it might be more now because that data is about a year old, a full 1/3 of OBGYNs have left the state of Idaho. The state of Idaho has between 200 and 210 OBGYNs left for the entire state. For the entire state. That means you might live 3 hours away from the nearest OBGYN, 4 hours away from the nearest hospital that can provide some kind of maternity care. A maternal health desert exists when the county that you live in, you do not have access to an OB or a hospital with maternity care. Those flights are going right over me right now, y'all.
That's a life flight. I'm just kidding.
Yeah, maybe they're life flighting these planes out for this hurricane. Planes are worth a lot of money. So a lot of times the airports and the military get their planes out of here before the hurricane hits. It kind of makes sense, but it is annoying for us. So
I lived in Destin for a while. Are you in the Panhandle? Are you, because you're on Central?
Oh yeah,
okay.
super close to Destin.
All the military bases and stuff. Okay, I know exactly where you are.
Yeah, they're flying out all those planes, as they should, right? They're worth like millions and millions of dollars. But so when we're talking about maternal health deserts, those are getting bigger and bigger and bigger because doctors are leaving these abortion ban states. We had data years ago that said that by 2030, the United States was going to hit an OB crisis. We didn't have enough OBGYNs to cover the population. This is partially due to an aging population. A lot of doctors were going to retire, but it's also due to the fact that doctors are moving out of these abortion ban states. At the time that the original data was coming out, Roe was still in play, and we didn't have the Dobbs decision. So they estimated that by 2030, we were going to hit an OBGYN crisis, and we were going to have something like 30,000 less OBGYNs than we needed. Now, by 2030, we're going to have an even worse crisis on our hands because we have about an 8 to 10% decrease in doctors wanting to go into OBGYN care. They don't want this career anymore. Same thing with ER doctors. ER doctors were actually seeing a bigger decrease. So in ER doctors, we're actually seeing about a 20% decrease in doctors wanting to go into emergency care. So we're going to hit an emergency care crisis as well. We're not going to have enough emergency care doctors. What that looks like, we've already seen a large amount of maternity wards, birthing wards, right? Where you go to have your baby. So if you've had a baby, you went into the maternity ward, right? Those are closing down across the United States. Number one, hospitals don't want to do it anymore. Medicaid is the single biggest payer of maternity care in the US. The single biggest payer. Medicaid does not reimburse well for maternity care. The amount that Medicaid reimburses a hospital is less than what it costs the hospital to provide you that care. So they actually lose money usually on the maternity wards. The maternity wards are kept running by like Blue Cross Blue Shield, United Healthcare, the private payer insurances. If you work in an area that is very rural or very poor, you probably don't have a lot of private pay insurance. And it probably costs your hospital, you lose money on maternity wards. Do you think hospitals give a shit about having a maternity ward because that's what the community needs? No, they care about business and money. These hospitals are about business and money. Capitalism. So if your maternity ward isn't making you money, you're going to shut it down. Also, if you don't have enough doctors to staff your maternity ward because you're increasing maternal health deserts and OBGYNs are fleeing the state to work in blue states where they can actually provide the full spectrum of medical care that they are trained to provide, you're going to shut down your maternity ward because you don't have enough providers. So now, instead of you living 20 minutes away from your OB in a maternity ward, when you have a complicated pregnancy like Candi Miller would have had, Georgia, so a third of the US lives in a maternal health desert. In Georgia, it's 50%. In Georgia, 50% of people in Georgia live in a maternal health desert. That means they do not have immediate or easy access to OB or maternal care. If you live that far away and you're Candi Miller and you have lupus and diabetes and hypertension and you have an extremely high risk pregnancy, if you are over an hour away from the nearest hospital that can provide you care, you've got a serious problem on your hands. You've got a very serious problem on your hands, right? Think about what that actually looks like on the ground. You can call 911. I don't know how fast they're going to get you there. You're still an hour away. You might be 2 hours away. I also want you to think about how often when we're talking about Medicaid being the biggest payer of maternity care in the US, that's for low-income people, right? Do you think that people who are living paycheck to paycheck, who cannot miss work, do you think that they have the time to take off work to travel 2 hours for prenatal care? 2 hours there, 2 hours back. They don't. So we also know that if you live in a maternal health desert, you find out about pregnancy later usually, and you initiate prenatal care later usually. However, what we're finding throughout the US, I'm seeing it a lot here in Florida. A lot of OBGYNs are refusing to see patients until 12 weeks of pregnancy. They will not see you until you are through that first trimester. And they're doing that for a couple reasons. Number one, they're overloaded. They just don't have the space. Number two, if you don't have the space and the bulk of miscarriages happen in that first trimester, you're going to take care of the people in the second trimester first, right? You're going to try to, if you need to see as many patients as you can, the patients that you feel like you can push to later, you're going to push to later because you literally don't have the time. But the other thing is, because the bulk of miscarriages occur before that 12-week mark, they don't want to take on the liability. Because if you have a miscarriage under my care and I can't provide you with miscarriage care, that fucking sucks. My hands are tied, right? Doctors don't want their hands to be tied. But if I never take you on as a patient in the first place, it's not on me. You just have to go to the ER, right? So number one, they don't have time. They have too high of a patient load to begin with. And number two, it's too risky to take somebody on before 12 weeks. So a lot of places, I'm not saying everywhere, definitely not saying everywhere, a lot of places in Florida, people are not being seen for prenatal care until they're already past the first trimester. That's going to increase your risk for a lot of things too. That's going to increase your risk for a lot of things for the baby, right? So these are all these are interconnected. That's what I need people to understand, is these abortion bans do not exist in a vacuum. This is not just about abortion and abortion care. This stuff has spiderweb effects that are going out across the US. Places that have maternal health deserts are also very likely to be contraception deserts. That means that in your county, you do not have access to the full range of contraceptive care that you need. So if you don't have access to contraceptive care, we're going to see more unplanned pregnancies. We're going to see more pregnancies in people that have pre-existing health conditions where they never intended to get pregnant in the first place, right? So we don't see this in men's health care. We don't see this kind of lack of access. We don't see this kind of lack of care, right? This is purely an AFAB and women's healthcare issue. And we got here because of all of these abortion bans. We already had issues with maternal mortality. We already had issues with maternal and contraceptive deserts. This has just exacerbated a previously existing issue, which, by the way, doesn't exist in other high-income countries.
We all are moving to Sweden. I want to talk to you about delay of care. I always take notes when you speak, and you were talking about delay in care. And then one of the things I was reading about last night was just right now part of the largest maternal desert we have in America, the conservative South, is Louisiana, where soon, right, it might be within days, it's going to take effect that now mifepristone and other abortion pill, related, I can't remember the other name, but they're basically controlled substances. And this is again 14 in the helpful resources and articles I provided last night. It's in the live sources section in the Discord. It's called Louisiana Hospitals and Pharmacists Prep for New Abortion Pill Rules. A state law taking effect October 1. So we just have days, right? Will be the first in the country to categorize mifepristone and misoprostol as controlled dangerous substances. So what's being talked about in this article? We're talking about the delay in care in maternal deserts of a life flight, of having to get on a helicopter. But this is interviewing nurses in hospitals in Louisiana who are saying they're doing timed drills, practicing running and getting to these machines that can dispense controlled substances because they have personally witnessed and know that they have lost lives in the time that it's going to take them, I'm not going to cry, to run to these machines. And get back. And someone's going to bleed out that fast. And every day we have Republican men, conservatives in politics, making it harder for women to live.
So in Louisiana, they have now reclassified misoprostol and mifepristone, both of the pills needed for a medication abortion, as a controlled substance. So when you classify something, so if anyone's not familiar with a controlled substance, there's different levels of controlled substance, right? So they have classified the abortion pill, both of them, as essentially in the same class as Valium and Xanax, right? So that is Valium and Xanax are a benzodiazepine. We often use them for anxiety and things like that. If you've ever been on a long overhaul flight and you ask your doctor, give me something for anxiety, you probably got Valium, right? It's a very relatively common medication, but When something is a controlled substance, there's a whole lot more rules and regulations around it, right? So penicillin, not a controlled substance, doesn't have as much rules and regulations surrounding it as Valium and Xanax. So why is something classified as a controlled substance? Things are classified as a controlled substance if they're dangerous and or addictive, right? We look at the addictive potential and we look at how dangerous it is. I'm not going to talk about I'm not going to compare it to other controlled substances because I feel like we might get kicked if we do. It might get mad at us. But when you classify these things as controlled substances, what usually happens is in the maternity ward, these things are on what we call a crash cart. That means that if something goes wrong in your pregnancy, if you start hemorrhaging, if you pass out, like something goes wrong, your blood pressure skyrockets or something like that, right? If anyone's ever had to have an emergency C-section where they're like, we're going right now, right? You probably had a crash cart near you. You probably had it in the room with you if they kind of saw this going downhill. Sometimes that stuff happens so fast that you're just going to the C-section, right? I've definitely seen women with a doctor with their hand up their vagina saying, keep that baby in, we're going to the C-section, right? We're going to the OR. These things can go downhill so fast. If you have something like placenta previa, which means that the placenta is covering the opening to the cervix, right? So if you're having a baby and the placenta is covering that and the baby's trying to come out, that's extremely, extremely dangerous. That is a very, very high bleed potential. But what if for some reason it's not caught, right? And then you start hemorrhaging. On the crash cart is these medications, and they're right there readily available because they're not dangerous medications, right? We're not talking about narcotic pain medication here. We're not talking about a medication that people want to hoard like they do opiates, right? So they're on a crash cart. When you classify something as a controlled substance, often hospitals have these things called a Pyxis machine. A Pyxis machine keeps a lot of the medication on the floor that doctors or nurses might need to access quickly, but they have to be behind a locked, controlled system because they're a narcotic. Maybe it's Valium, maybe it's morphine. You have to keep morphine on the floor because you have a lot of patients in pain. Or again, we often keep pain medication on the floor for maternity wards because people epidurals exist, but there's also other pain medication that you can take. If you now have to access a Pyxis, that means that you have to put in a code. You have to scan your ID badge. Controlled medications, for good reason, right, are tracked very heavily in the hospital. If you take out, let's say morphine, I should be able to go back and look at that Pyxis and tell who took it out, what time they took it out, and what room it went to, right? But all of that stuff is behind lock and key. It may not be in a Pyxis. Every hospital is different, and Pyxis costs a lot of money, right? But they still have to be locked up. They still cannot be easily accessible. They can't be on the crash carts. So what doctors are doing in Louisiana is they're running timed drills, right? Going from the furthest patient room to where you have to go to access the medication. And they're timing the doctors and the nurses to see how fast can you run all the way to the end of that hall, access that medication, get it out, document it the way that you're supposed to document it. So that way we know who took the medication out, what time they took that medication out, what room is it going to. You also have to document the exact time that you gave that medication. You have to scan the patient's ID band. You have to scan the medication. You have to get it into the computer, right? All that stuff. Sometimes people the Attorney General of Louisiana actually came out and made a statement this morning. It's bullshit. It's a terrible statement. She's basically saying that, oh, everybody's lying. This isn't gonna cause a delay in care. Tell me you've never worked in a hospital without telling me, right? You're not on the floor. You don't know what this looks like. So if it takes that nurse, if we're timing that nurse or we're timing that doctor, and it takes them an additional 6 minutes to run to the end of the hall, get that medication out, run back to you and get you that medication, you might have bled out by then. Or you might have lost so much blood that now you're in you were already in a medical emergency. Now it's become even more emergent, right? Now I have to deal with the fact that you've lost so much blood. Now I have to deal with the fact that you might have an increased bleeding risk later. Now I have to deal with the fact that you might have an increased risk of infection or something like that. When it's there and available on the crash cart, grab it, give it, you're done. It's right there, right? Think of like a heart attack. There's heart attack crash cards. There's medication that are on those heart attack crash cards. The reason that medication is on there is so you can immediately administer that medication, because seconds matter. Seconds matter in these situations, not minutes. Seconds matter in these situations. You have no idea how much somebody can bleed when they are in labor or they are having a miscarriage. When you have a hemorrhage, this is really serious. We have seconds to initiate care. And now we have to give it minutes. Now we have even longer, because in Louisiana, they have classified this medication as a dangerous medication, and it is now a controlled substance.
And this would never happen. I think it was very apropos that Kamala Harris asked Brett Kavanaugh at his confirmation hearing, can you name for me a time, like a case in the United States when men's bodily autonomy has been violated? And of course he could not, because just like you said, this does not happen to men in this country.
So I can name one. There is one singular law in the United States that does affect a man's bodily autonomy. Does anyone in the comments know what it is? There's one.
Found one in the Netherlands, or a recent ruling. But I'm not sure.
So no one seems to, it is the selective service. It's the selective service. Every man, when he hits 18, he's required, someone said it, selective service in the draft. Every single man, when he hits 18, is required to register for the selective service. We haven't used the selective service since Roe. We haven't used the selective service since, I think it was 1972, maybe it's 1974, right? I think it's been like 52 years. It's been more than 50. So I'm going to go ahead and say 72. I've got a lot of data in this brain, y'all. Sometimes it gets discombobulated, but I'm going to go ahead and say 72. We haven't used the draft in over 50 years. Over 50 years. And the draft is based on misogyny. The draft is not based on misandry. It's not based on, well, it is based on misandry, but it's not
hate men, let's send them to war to die. Yeah.
Right. Like, it's based on the idea, if you consider misandry patriarchy, right? The fact that like men are disposable, men are just worker bees that are disposable. And so we can send them to war as part of this like war machine. Sure, you can say it's based on misandry, but it's not based on women hating men, right? The draft is based on misogyny. It's based on the idea that women are these super delicate beings that just can't possibly be recruited for war. We need the big, crazy, strong men folk to go out and save us from this war. That's what the draft is based on. And guess who made the draft? Because it wasn't us, right? Men made the draft, and we don't even use it anymore. So that is the only law that is technically still on the books that controls men's bodily autonomy. We don't use it anymore, and I haven't met a single man complaining about this that has ever been affected by the draft. Not one. Someone said, like, what women had a vote to draft men in Congress? Nobody. Like, we didn't create the draft. Women didn't create the draft. It was a creation by men, right? And I'm also fully in favor of abolishing the draft. We don't need it anymore. We don't use it anymore. We have an all voluntary military force, right? We have more than enough people in the military to not have to use the draft. I'm fully in favor of abolishing the draft. We'll abolish the draft when you abolish abortion bans.
Yeah, and the other way around, like selective service, I'm also okay being part of it as well. Like the idea that women are somehow deficient and cannot be part of a military selective service, right, is also ludicrous to me. I wanted to ask or bring up one other thing and think and ask what your thoughts on it. Another recent article that has come out and that was very disturbing to me in my research, and I'll figure out this is in one of the 20 articles I put out. I'm just not sure what number. It's one of the Washington Post ones, but it basically says that infant death rates, right, spiked in Texas after their restrictive abortion law. Studies has found that between 2021 and 2022, the infant mortality rate increased by 8.3% in Texas compared with a 2.2% increase nationally. The Texas rate reflected a 12.9% increase in the actual number of deaths of children before their first birthday, and while the death rate of babies 28 days old or younger fell in other states overall, it increased by 5.8% in Texas. Infant deaths from fetal abnormalities, the leading cause of deaths for for babies under a year of age, rose by 22.9% in Texas in 2022, but fell by 3.1% for the rest of the country. So, and this is, I mean, this article is quite disturbing. I'll find the article, but what are your thoughts on that?
So and I'm looking this up really quick. I want to get you guys a stat.
Oh, it's number 7. Yeah, it's infant. Yeah, it's a Washington Post article. It's called "Infant Death Rate Spiked in Texas After a Restrictive Abortion Law Study Finds," and this is a Johns Hopkins study, and from JAMA Pediatrics. Let me see.
So thoughts on that? A lot of people are going to say, which this is true, not denying that this is true. Of course, of course, infant mortality rates are going to increase when you're forcing somebody to carry a pregnancy to term that was never viable in the first place, right? So if you terminate a pregnancy, if you find out that this pregnancy isn't viable because the fetus has an abnormality or an anomaly that is not compatible with life, most of the time people would terminate those pregnancies, and they had the ability to do that. Continuing those pregnancies can be extremely risky to your health, depending on what it is. So some abnormalities and fetal anomalies can cause risk of health to the pregnant person. Some people just choose to terminate those pregnancies because they have no interest in giving birth to a child without a brain. They have no interest in giving birth to a child that stopped developing at 13 weeks, right? And that's okay. You shouldn't have to go through the entire birthing process and an entire 40-week-long pregnancy with a dead fetus inside of you, or knowing that your baby is going to die within seconds of you giving birth to it, or knowing that your baby is just never going to live, right? You shouldn't have to do that. But in Texas and in many states, you are required to carry that pregnancy to term. You are forced to carry that pregnancy to term whether you want to or not. So then when those fetus are born, they die. They die relatively quickly after birth, right? Some in seconds, some in minutes, some never even take a breath. Some never have their lungs developed enough to ever breathe. But that is horrifically traumatic for a family. And I'm not even going to say for the pregnant person, because I want men to start realizing that this affects you too. This affects you. If your wife or your partner is pregnant, and then you find out that there is a fetal anomaly that is not compatible with life, and then she is forced to continue that pregnancy, you have to watch her continue that pregnancy. You have to support her through that and watch her cry almost every single day, because that's what happens, because they know that this pregnancy isn't viable, but they don't have a choice and they're forced to carry it. So when you're forced to carry a doomed pregnancy, then yes, infant death rates or infant mortality rates are going to go up, right? Of course they are. But the other thing, remember those maternal mortality or those maternal health deserts. So 1/3 of the US, 33% of people in the US overall live in a maternal health desert. However, in Texas, which this is the number I want to look up for you, it's 46.5%. So 33% is the national average. Texas is at 46.5%. That's higher than the national average, right? When you live in a desert, you're not getting the prenatal care that you need. When you don't get prenatal care, infant death rates do go up, right? Because you're not getting the nutrients you need. You may not be getting the medication you need. You may not be getting supplements you need. You may not be getting prenatal care that you need to get to ensure that you have a healthy pregnancy. So when we started initiating prenatal care, maternal and infant mortality, but mortality rates went down, right? Go back to like the 1800s. Maternal and infant death rates were much, much higher, right? When we started initiating prenatal and postpartum care, infant and maternal mortality rates went down, right? In the US, we have horrible postpartum care. Horrible postpartum care. In places in Europe, you get visits from a postpartum nurse that comes to your house and goes to your house and helps you figure out how to breastfeed. So if you're having issues breastfeeding, they will help you figure that out. They will help you get to latch. If you have questions about the baby, about their poop, about their nutrition, about what you're feeding them, they will help you through all of that. If you have questions about, is this a safe sleeping arrangement for my baby? They will answer all of that for you. We don't have any of that in the US. And a lot of women don't even get postpartum care because if you live 2 hours away from your OBGYN, what you don't want to do after you've already had to take off probably 2 weeks to have this baby is take off more time to travel 2 hours there and 2 hours back for a postpartum visit. So we are going to see these infant death rates. We're seeing maternal mortality increase. We're going to see infant mortality increase too, because we don't actually care about taking care of pregnant people or taking care of them and their children postpartum. They only care about forcing you to continue that pregnancy.
Exactly. That's because it's not necessarily like causation. I mean, but yeah, it's like the fact that also that the commonest cause of early infant deaths is congenital abnormalities. And the strict law banning induced abortions after embryonic cardiac activity with no exceptions for congenital anomalies makes a causative link much more probable. I mean, you don't know you're pregnant at 6 weeks. Most women have no idea they're pregnant, let alone by then could know if there's fetal abnormalities that are going to take them down this road.
Right. And that's kind of the thing is like, if you can't get ultrasounds regularly, right? Because you live far away, you may not catch an anomaly. You may not catch it till late. So even in Florida, and this is one that I love to point out because people love to say like, let me find this case. Oh, I can't think of the name right now.
While she's doing that, I'll just say this also, which is super disturbing, is the interesting thing, or not the interest, I guess it's not surprising at all, right? But it's just that researchers also said that the existing evidence suggests a higher incidence of infant deaths, right, among non-Hispanic Black women due to abortion restrictions, as well as the impact of infant mortality on parental well-being more broadly, right? Like Danielle is saying, this disproportionately affects minority groups who don't have access to prenatal and postnatal care. This is not because, minority groups don't care for their children the same way. They don't have access to the care and the early detection that they need.
And on top of that, we have a horribly racist medical system, right? So I love to give Serena Williams as an example. Serena Williams almost died after having her baby. She almost died from postpartum hemorrhage. She was in the hospital. Y'all, Serena Williams, she has access to the best OB care in the country. This is not somebody living in Louisiana in the rural areas, right? That doesn't have access to care. This is not somebody that didn't have any prenatal care. This is somebody that had access to the best care in the US. And she sat in that hospital bed telling her doctors something is wrong. Something doesn't feel right. I don't feel well. Something is wrong. Run tests. Somebody help me. Something is wrong. And she almost died because doctors didn't care to listen to a Black woman. And we see this over and over and over again. This is why maternal death rates for Black women are 2.5 to 3 times higher. If you are a Black woman who lives in a state with an abortion ban, which the South has a very, very high percentage of our Black population in the United States, you are 3 times more likely to die of a pregnancy complication than if you are a Black woman who lives in Washington State, for example. If you live in Louisiana, you are 3 times more likely to die in pregnancy or childbirth as a Black woman than if you lived in Washington. Your state on its own is a significant risk factor for whether or not you will survive this pregnancy. And I believe
Just
Serena
by
Williams
Amber
was like in
Thurman
California.
being in Georgia. Yeah, just by Amber Williams being in Georgia, right? And committing the absolute crime of being a black woman, right? Already she's behind the eight ball. The odds are against her just because of her location and being born black, that she is going to survive. That is the situation we're in. And I just, like, what Danielle said is so important. I want to make sure we say it really simply so you understand, because it was one of the things that really shocked me when I started learning about misogynoir, which is, you know, misogyny against black women, specifically in medicine, right? And unconscious bias is that as your socioeconomic position in society improves, right? As black women gain more money, right? Better jobs, their chances of survival do not increase. Just like what we're seeing with Serena Williams. Serena Williams, this is a recognizable, famous, you know, one of the most elite athletes to ever have existed in this world, right? Is wealthy beyond most of our imaginations and cannot, as a black woman, get the care that she needs to survive. That is the reality that black women are facing in this country, that Amber Thurman faced, that Candi Miller faced.
I also like to point out, because I think this gets missed a whole lot, and I don't think I've ever talked about, well, maybe I've talked about this on a live one time. So we know that the black, and also, by the way, the Hispanic Latina maternal mortality, also higher than white women, right? Not as high as black women, but also higher than white women. The indigenous maternal mortality rate, the maternal mortality rate for indigenous women, we don't really know what it is because we don't care enough to really track it. We don't care enough in the US to really track it. But the best number I have, 40.3. 40.3. Horrific. Horrific. I want to remind you that the maternal mortality for places like France is like 7. 40.3 for indigenous women.
That's 7 in 100,000, right? When you talk about these rates, I just want to explain.
It's 40.3 per 100,000.
That's okay. So I just want to make sure we understand like how high this is, right? We talk about missing and murdered indigenous women. They can't even get out. They can't even successfully have a child, like let alone all the other dangers they face.
And just so you know where this has gone, and again, we do not track this number well. We don't track this number as well as we track other ones, right? From 1999, in 1999, the mortality rate for indigenous women was 16.2%. It is now 40.3. 40.3. We're going backwards. And who do you think is most likely to live in a maternal health desert? Who do you think is at higher risk of living hours away from OB care, living hours away from emergency OB care if they need to? Black women and indigenous women, right? Especially I saw someone mention Mississippi. Mississippi, abysmal. One of the worst states in the country, if not the worst. A lot of the southern states like to compete every year for who gets to be like the worst of the worst. But Mississippi is consistently in there. And Mississippi, I believe last I checked, has the highest Black population of any state in the country if we're talking about per capita. So when we talk about maternal mortality rates, Mississippi and Louisiana, you're at high risk. If you live in Mississippi or Louisiana as a Black or indigenous woman, you're at extremely high risk in pregnancy, extremely high risk. People in these states are looking at this and going, I don't have any interest in having kids or getting pregnant. And then we have the country going, why is the US birth rate so low? What's going on with the US birth rate? Why don't women want to have babies anymore? And they sit there and like all the articles that I see, like I get so enraged about it. Because every article I see is like, well, we think women don't want to have babies anymore because they're going for education. And so they're delaying having kids because women are choosing education.
They're selfish, Danielle. We're selfish.
How can I go get a doctorate degree? I'm such a selfish asshole. But women are delaying it because of because of schooling. And then they'll say, well, women are delaying marriage because of schooling. They're delaying marriage and having kids because of career choices. All of that is true, but women are not having kids because women are not happy with men. Women are not having kids because they're sick of having kids with men who are not active fathers, who are not active partners, who are not participants. The amount of women who tell me, I would love to be a parent if I could be a dad. If I could be a dad, I'd be a parent all day long. But if I have to be a mom,
Amen.
Forget it. Forget it. I don't want to be a mom, right? I'll be the dad. I'll be the one that steps in for like all the fun times. I'll be the one that gets to come home from work and just doom scroll on my phone or go to the bathroom and take a shit for 45 minutes, right? Like I'll be a dad, but I don't have any interest in being a mom. That's too much work. Women don't want to have kids with these men. Women don't want to have kids with these men making these abortion laws. Like, yeah, we're delaying having kids because women are more educated than men now. We have more women getting undergraduate, graduate, med school, and law school degrees now than men. Women are more educated than men in the US now. They don't want to have kids with a man that's only going to set them back and bring them down.
Oh my God, preach to the choir. No, I could not agree with you more. And I think I read a lot of psychological studies because it was previously believed like, and this is happening in China, right? Like South Korea, the 4B movement, like women are refusing to have children. This is happening in developed countries around the world and also in America. And you see people saying, or it was previously thought that this was an economic situation, right? If people aren't having kids, we just need to improve the economic situation. We need to drag women back to the 50s when a one income household could provide. And as long as we can get in the right economic system or situation, women will have babies. But now we're seeing this is very much not true, right? Because where are people having the most babies right now? In absolute poverty. Bad Views and I were reading an article about this yesterday together. In absolute poverty in Africa, there will be more, by like 2030, there will be more average working age people in Africa than in the entire rest of the world combined, right? This has nothing to do with economic opportunity. It's psychological, right? You're not going to bring children into a situation that you don't enjoy being in yourself, that you don't believe there's upward mobility and that you don't believe there's a chance for your child, particularly your daughters, to survive, right? And that's what obviously men are underestimating, right? And that's why we're now in these forced birth situations in the South and Idaho. I have a question for you. Someone.
Oh, go ahead.
Oh, yeah. So Tanya said, and I think this is a great question to always, because just with the debates and the presidential election coming up, Tanya says, can Danielle explain why someone would need a late term or post-birth abortion happening after 20-week anatomy scan?
So there's no such thing as a post-birth abortion. That's called infanticide, and it's illegal in all 50 U.S. states, right? So like, we'll just get that one out of there. There's no such thing as, so first of all, what is an abortion? It is removing the contents of the uterus, right? It is terminating a pregnancy and removing the contents of the uterus. There is no such thing as a post-birth abortion. That is an oxymoron, right? It does not exist because an abortion is terminating a pregnancy out of the uterus. That's called infanticide. That's called unaliving, right? We don't allow that anywhere. So why would someone need a, what we call like later term abortion, right? Fetal anatomy scans happen usually around 18 to 21 weeks. Sometimes they can happen at 22 weeks, right? They can happen usually anywhere after that 18-week mark. I've had a couple people say like, well, I think I got mine around like 16 weeks. Remember, we also are not dating pregnancies exactly. There's a reason that you're considered full term, like anywhere between 38, 39 to like 42 weeks, because we can be about 2 weeks off ish, right? On when your last, it's dated from the first day of your last menstrual period. Well, you weren't pregnant during your last menstrual period, were you? You weren't. But we date it from the first day of your last menstrual period because that's the best way for us to date it. So people often have these fetal anatomy scans. You can definitely have other testing done beforehand. right? Sometimes people find out that they have a non-viable pregnancy at 12 weeks due to other testing that happens, right? I saw someone in the comments say, I didn't get my scan until 24 weeks. That's becoming more and more common because, again, we have maternal health deserts, and they also have to get you in to get the scan. And if we have less hospitals that have abilities or less doctors' offices that have abilities to do these scans are going to get pushed later and later and later into pregnancy. So let's say you have a fetal anatomy scan at 24 weeks. Let's just play that fun game. You have a fetal anatomy scan at 24 weeks. It comes back that your fetus has like ancephaly, right? Not compatible with life. So if that's the case, do you want to continue that pregnancy? Or do you, and I'm going to read, I just looked up ancephaly because I know that everyone's going to do this. It's essentially like a brain condition, and it is not compatible with life. But I want to note this. This is the first thing that comes up because I know people aren't going to believe me. Ancephaly is a fatal birth defect that occurs when a baby is born without parts of their brain or skull. It is a type of neural tube defect that happens when the neural tube doesn't close completely during the first few weeks of embryonic development. That means that this fetus has had this since the first couple weeks, but we didn't catch it until your fetal anatomy scan. And then you have the fetal anatomy scan. And by the way, if people get to 24 weeks, this is generally a very wanted pregnancy. This is generally a pregnancy that they very much wanted, right? So then you find this out, and you find out that this isn't compatible with life. In Texas, you're going to carry that to term. You don't have a choice. That's what happened to Kate Cox. I don't believe that was the diagnosis of her fetus. I think it had trisomy, if I recall correctly. It had a form of there's a couple forms of trisomy, but I can't remember 18. I want to say that she had trisomy 18. But either way, not compatible with life, right? So then you can make the decision to terminate that pregnancy somewhere else. There's a handful of states in the country that do allow abortion past that point. And people look at those states and they say, why would you not have any kind of restriction? Why would you allow abortion at any point during pregnancy? Because these things happen at any point during pregnancy, right? Someone can be at 30 weeks and find out that something is seriously wrong. So there's a whole host of medical reasons. There's a whole host of fetal anomalies and defects that can be diagnosed during that fetal anatomy scan that we cannot diagnose before that point. And once you get that diagnosis, it should be your choice, your decision, how you want to proceed. And you should have all the options available. And as a provider, your job is to provide your patient with all the options available. Except if you live in an abortion ban state, sometimes providing your patient with that information is a crime all by itself. There are doctors in places like Tennessee that won't even talk to their patients about that being an option. Yenny in Texas, the woman that died in 2022, her doctor didn't even give her the option. The word and the comment of terminating this pregnancy or getting an abortion was never even given to her. She was told to go home, be on bed rest, continue the pregnancy. We're going to put you on medication. She was told it was life-threatening, but she was never told, hey, if you want to leave the state, you can get an abortion somewhere else, and that might be the best option for you. Her doctor never gave that option because her doctor was too afraid to even recommend it, because her doctor was afraid that by recommending it, that would be committing a crime. Same thing in Tennessee. Doctors can't even give referrals. In Georgia, one of the women, I mentioned that YouTube video, right? One of the women that is testifying, that testified last week, that said that I was not able to get an abortion, she said, my doctor had a conversation with me and said, this is off the record. This is not going in your medical chart, and you cannot call the office back to ask questions about this. If you want to leave the state to get an abortion, you can. And that is probably the recommended course of treatment here, right? Off the record. We have to have these conversations off the record, because even providing a referral to an abortion clinic out of the state can be seen as aiding and abetting in an abortion. which that's free speech, right? These are going to be challenged under free speech, and some of them have been, and some of them have been blocked. But still, look at this culture of fear that is being created for providers. And in Alabama, y'all, that's 99 years in prison.
It's terrifying. And I think, I can't remember who we were talking to who was bringing this up, but I think that's also maybe speak to that a little bit. Because I think it's like, where do women direct their frustration, right? Like because we get so upset and we're like, okay, thinking about Amber Thurman suffering for 20 hours in a hospital, and we want to be like, God, these doctors. But right, they are in a uniquely, their hands are tied behind their back, like as well. Like, and it's sad because who does Amber Thurman's, one of the most heartbreaking parts for me about that ProPublica article is that ProPublica has to say in that article, Amber Thurman's family did not know what had happened to her, did not understand that her death was preventable until ProPublica informed the family what had happened. They had tried to get her full medical records from the hospital and could not get them, right? And so I think that it's hard because we need to understand how bad the plight of the medical providers as well. And so what does Amber Thurman's, who do they go after? Oh yeah, it was Nurse Bachhold, one of our community members here, who was kind of trying to explain the juxtaposition to us. It's like, okay, well, Amber Thurman can go after the providers, the hospital, which is actually punishing them because now we have providers who are going to be more fearful of providing care. Right? So what is the answer?
And let me come back to like, what is the answer? But I'll also remind people that a lot of times, like, let's look at Amber Thurman's case as an example. Why was there a 2-hour lag? I don't know that answer for sure, right? But I'm going to make some suggestions. Why was there a 2-hour lag between the time that the ICU doctor said, we need to do this procedure, and the time that they actually initiated care in the OR 2 hours later? Because a lot of times your doctor is not making these medical decisions. Most of the time, especially if you're in a big hospital system or something like that, which, by the way, about 1/3 of hospital systems in the US are religiously affiliated, either Catholic, Baptist, right? They are not going to give you that abortion. They weren't going to give you that abortion before Roe overturned in the first place. They would have transferred you to another hospital if you asked for it, but now they're not even going to do that, right? So most of the time, the people making those medical decisions of whether or not you can initiate that care, hospital administration and their lawyers. It's the legal team of the hospital and it's the admin team. So you as a doctor are sitting there documenting. You're trying to put everything you can in the medical record. You're trying to clearly state that, like, this is an imminent risk. This is why I believe that this is an imminent risk. Look at these white blood cell counts. Look at these organ failures that are coming up in labs, right? You're going to document the crap out of that case, which, by the way, takes a lot of time. Unless I have like what we call Dragon software or something like that, which is where we dictate it. Right? Like we can dictate, like, patient came in at 6:51 p.m., blah, 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 blah. It can take me a really long time to write a note, y'all, especially if I'm trying to document something that might come back to bite me in the ass later. I'm going to document the crap out of that. And writing that note might take me 30 minutes, 40 minutes, because I have to justify everything. Right? A DNC is needed because of this. This patient came in at this time. This patient has deteriorated. This is how I know this patient has deteriorated. These are the lab results that tell me that this is a life-threatening situation. This is the care that has already been initiated and tried. We tried to give IV fluids. We tried to give IV antibiotics. We tried to give Levophed. You have to document every single thing because hospital admin and their lawyers are going to read that. And they're going to look over your notes and go, she's not sick enough yet. Nope. So as a provider, you don't want to be you don't want the lack of your documentation to be the reason that care was denied. Right? So in those situations, it's not always them that is making that decision. And I'll tell you a story in a second. I do have a pretty decent story about how that actually works in real life. But in terms of like, who do we go after? You can try to go after the hospital itself, right? Like, you're going to probably have better outcomes going after the hospital than you will the doctor, because guess who makes a lot more money? The hospital. So you're going to go after the hospital. The doctors feel like their hands are tied, right? Most of the time, these doctors are begging to do this procedure, right? And I'm not saying that's what happened in this case. I'm not saying that because I wasn't there and it doesn't reflect it in the medical record. But what I am saying is that the delay of care often comes from the top. So you can try to go after the hospital, but guess what the hospital is going to do? Point to the abortion ban. They're going to point to the abortion ban and say, we were following law. What do you mean? We were following the law. And one of the things that comes up in the Georgia abortion ban, which let me be clear, I don't think they would have provided the care anyway, because I don't trust them to provide the care, because we know that in Florida, care wasn't provided. Even when we had the 15-week ban and people came in with a miscarriage, people were sent home to have their miscarriage at home, right? Or we had somebody that like gave birth in a hospital parking lot to like a 15 or 16-week fetus. So I don't think that they would have initiated care. But in the Georgia abortion ban, there is a clause that says it is not an abortion if you are removing a dead fetus that was caused by a spontaneous miscarriage. It doesn't say if you're removing a dead fetus caused by the abortion pill. It doesn't say if you're removing a dead fetus due to an elective procedure, which, by the way, I hate the term elective abortion, but it doesn't say that. It says if you are providing a DNC due to a spontaneous miscarriage and retain what we call retained products of conception. That's how it's noted in your, that's how it's billed to insurance and noted usually is retained products of conception. So Amber didn't have a spontaneous abortion. She had a medical abortion and she was honest about it. So they can look at that and the hospital is going to say, the abortion ban doesn't allow us to do an abortion in these cases. The abortion ban doesn't allow us to do a DNC in these cases. Look at how this is worded in the law. It says due to a spontaneous abortion. This was not a spontaneous abortion. This was an initiated abortion. Our hands were tied. We couldn't provide anything, right? So people look at it and they're like, well, who can we sue? Who can we go after? You can try. You can definitely try. And I'm never going to discourage somebody from trying, right? But I don't know if it's going to play out well for you legally. And definitely anti-abortion organizations are going to show up to that. We saw, I can't remember this person's name because I don't care to remember their name, honestly, but the head of Susan B. Anthony, Pro-Life America, which, by the way, what an insulting name, regardless, she did an interview on Fox News where she laughed. She was smiling and laughing. And she was like, yeah, they say that women are dying. They say that women can't get care. Like, that's not true. Literally, ProPublica just published 2 articles where they gave names, gave receipts of these people dying because of these abortion bans. Yenny Alvarez died in Texas because of Texas abortion ban. And she laughed. So I want everyone to remember, these are the anti-choice groups in America, and they're laughing at you. They're laughing because they think that you deserve this. They think that women are meant to have babies and also they're meant to die for their pregnancies. That makes you a good woman. If you are willing to die for your pregnancy, if you're willing to die for this baby, that actually makes you a martyr and a good woman. That's what these people believe. So for them, abortion is never healthcare. And they're laughing at these deaths. She was being interviewed about the ProPublica articles and she laughed.
Yeah, and I want to cite one more source. I put it in the general area in the Discord, and I believe you and I discussed this before, Danielle, but there's a great ProPublica article just talking about this. It specifically focuses on Tennessee, where they have such a disgusting abortion ban. Their states banned abortion. Doctors now say they can't give women potentially life-saving care. And this details out, like what Danielle was describing, the fight of doctors in real time trying to type out pages of notes proving, please let me save my patient's life. Please let me do what I know this patient needs. And they are arguing in real time with hospital boards, with the people who make the decisions of whether or not a woman can live. And by and large, it absolutely is not the doctor. Or we saw in There are some recent lawsuits that came out in Texas. I believe it's in the outline I provided with some articles to read up before this live. I believe it's the last one, and it's about women who are suing because they couldn't get care for ectopic pregnancies, right? These are non-viable pregnancies. Implantation has occurred outside of the uterus, right? And it's like the story of an OBGYN who is pleading with a hospital, begging, pleading, writing notes, like getting collateral over days to try to say, please save this woman's life. And so that is the irony. And meanwhile, these people are laughing.
And Tennessee, by the way, one of the states that just had a part of, Tennessee has, I'm trying to debate if I can say this, but we're going to try it. Tennessee has an you know how when you drive to work and there's a lot of traffic to work and it's really annoying? They have a law for that. And one of the things that it says in that law is that you can't, it's for people that are underage, right? So anyone under the age of 18 specifically, they're calling it abortion T word to cross state lines with a teenager. But anybody who aids and abets in that can be charged. So if you're a grandma and you give your granddaughter money to go to North Carolina to get care, you can be charged. If you are someone's best friend and you drive them to North Carolina, you can be charged. If you are the partner of this woman and you drive her to North Carolina to get care, you can be charged. If you pay for it, you can be charged. If you text them a link to a clinic in North Carolina, you can be charged for aiding and abetting in an abortion. Now, that part, I believe, was blocked by Tennessee this week because they said it falls under free speech. It says that speech, you can't control speech, and you certainly can't control the speech from a provider to their patient in a private medical setting. So for that reason, I'm pretty sure, you can look it up, but I think that part has been blocked from the Tennessee bill.
It's in the outline. There's an article, I believe I provided, it's an NBC article, and it's in the live sources section that I provided to you guys last night that talks about that. So yeah, I did provide that. And then just one more resource that's interesting that I think everyone should see. Number 10 in the same outline in the live sources section is an interactive map from the New York Times, right? In 2023, 171,000 women traveled outside of these maternal deserts to receive abortion care. And you could see in real time, like the proliferation of like the roads they took and find out more information about it as they track it. So I invite everyone to look at that as well.
And I also like to tell people, so this is a story I said I was going to tell earlier, and I told it, I think with Jay last week, but I'm going to tell it here now too, because I think it's really important. And I do have permission to share this story. So my sister was pregnant recently. This happened this year. It only happened a couple months ago. She lives in Kansas. Kansas voted to protect abortion rights back in 2022. They were one of the first states to do it. You still cannot easily access abortion in Kansas. It is still extremely hard to access abortion. So my sister was pregnant. I already have one niece. She's 3 years old. She's stinking adorable. My sister was pregnant with a very, very wanted pregnancy. They'd been trying to get pregnant. My niece was born via IVF. They tried IVF a couple times. It was not successful. Then they naturally got pregnant on their own. Again, my niece is 3 years old. She's had a handful of miscarriages between then and now. And she finally, this pregnancy stuck, right? They were elated. They didn't tell anybody in our family. I mean, I knew, obviously, but they didn't tell anybody in our family until she was past that 12-week mark. So then she passes the 12-week mark. She announces to our family that she is again pregnant. She is now in her second trimester. At her 14-week appointment, they find out that the fetus has a severe anomaly and is not going to live. There is absolutely no way that it is compatible with life. And in fact, continuing the pregnancy would have caused severe health risks for her. They still would have liked to continue to get pregnant, right? And also there was 0% chance that this pregnancy was viable. She then went back, she had another appointment because she was like, let's make sure, I wanna make sure, right? This is a very, very wanted pregnancy. We tried to get pregnant for so long. I already announced to the entire family that I'm pregnant, because she was past that 12-week mark. She goes back, she has another test, she has another scan. The results are exactly the same. And it's even more clear now because she's another week along. And her doctor says to her, again, she's in Kansas. Abortion rights are protected, supposedly, in Kansas. Her doctor says, what do you want to do? You can, right? Like, you can continue this. These are the risks. This is what could happen. Or you can terminate the pregnancy. My sister says, I want to terminate the pregnancy. I can't do this. I can't do this, right? I can't walk around knowing that this is a doomed pregnancy, knowing that this fetus could die at any point in time, right? I don't want to do this. So her doctor's like, no problem, but I can't provide you the abortion because OBs aren't really providing abortions. And we can try to ask the hospital if we can do the abortion, but I bet they're going to deny it. So my sister's OB writes up a report, right? Remember I said, we're going to document the crap out of this. We're going to be like, these are the scans. These are the tests. This is why this is a justified reason. The hospital sends it back, denied, cannot provide an abortion, has to carry the pregnancy to term. She then does an appeal. Her OB does an appeal. Remember, we're pushing the pregnancy further and further and further along here while we're doing this. She was 14 weeks, now she's 15 weeks. The further and further along you go, the higher the risk of having a DNC, right? It's still an extremely safe procedure, but we want to have it done as early as possible. She writes the appeal. 2 days later, the hospital comes back. Absolutely not. Appeal denied. There's nowhere else for you to go. You can't get it at the hospital. Your doctor can't provide it. The hospital will not provide an OR for you to do it, and they will not provide nursing staff nor a nurse anesthetist to do it. So her only options were to go to Planned Parenthood. So everybody hates on Planned Parenthood because they're like, oh, well, they're just providing elective abortions, blah, blah, blah. First of all, I don't care. Provide as many elective abortions as you want, Planned Parenthood. But also, people who have very wanted pregnancies are required to go to Planned Parenthood because hospitals in states that protect abortion rights will not allow doctors to do them. So my sister begs her OB, please, Planned Parenthood can't get me in for at least 3 weeks. By then I'm going to be 18 weeks. Is there anything we can do? Her OB says, I have a colleague who is secretly providing abortions, but she doesn't want to be known as the OB that provides abortions. So it's really hush hush. Again, this is not illegal. This is not illegal. This is in a state that protects abortion rights. So she calls this colleague and she says, hey, I have this patient. This patient has gone through a lot. She's gone through multiple IVF treatments. She's gone through multiple miscarriages. She was pregnant with an extremely wanted pregnancy. She is now, 15 and a half-ish weeks along. Can you please provide the abortion so she doesn't have to wait 3 weeks to get into Planned Parenthood? This OB says, yes, I can provide an abortion. But my sister shows up to the appointment. She knows the appointment's going to happen in the office, right? But my sister is under the understanding. My sister's a nurse practitioner, by the way. She is not an uneducated person that doesn't know anything about medical care. She's a nurse practitioner. She shows up to the appointment and they were like, oh yeah, we don't provide anesthesia. We don't have a nurse anesthetist, so we can't provide anesthesia. My sister had to have a DNC with zero anesthesia. Nothing. The only thing she was given was a mild cervical block. That's it. And she was given stress balls or told she could squeeze the bed. That's it. She said it was the most horrific. By the way, this DNC took 22 minutes. 22 minutes. She said it was the most horrific, painful thing she'd ever been in her life, ever gone through in her entire life. She felt every single scrape. She felt the suction. Her cervix was dilated. Dilating your cervix, y'all. If you've never had your cervix dilated, holy shit, that will gut punch you. That will gut punch you. It's horrible. Had to have her cervix dilated and all the contents of a 15 and a half week pregnancy scraped out with zero anesthesia. Nothing. In a state that protects abortion rights. Because nobody will provide abortions because they're afraid of being known as the abortion doctor. They're afraid of people knowing that they provide them and their life being at risk or their clinic being at risk because protesters might show up or people might try to bomb the clinic or people might try to pew-pew them. I live in a city that unalived their abortion doctor a decade ago. So in Kansas, right? Where you have like some crazy Christian churches that will do this stuff, people are still providing abortions under the cloak of secrecy in a state that protects abortion rights because they're terrified. And now we have women that are literally being tortured because of these laws. There's no reason for this. There's absolutely no reason for this. 10 years ago, people that could get pregnant had better medical care and better access to that care than we do today in 2024.
God, I just want, my heart goes out. I just want to be sick. But yeah, and that's one of the things like that's interesting in these maternal deserts, like Georgia's one, where any, the anesthetist, the anesthesiologist can say, oh, from personal reasons, I'm not going to participate in this. Right? Anybody on the team, it takes more than one person, right, to do a DNC, right? And anybody at any time who's on staff at a hospital in Georgia can say, oh, for personal reasons, I'm not participating. And what do you do at that point? What do you do?
And think about, like, if you want to have anesthesia, right, you have to at least have a nurse anesthetist. There are other parameters that you have to meet as a clinic in order to provide anesthesia to your patient. In order to provide a cervical block, that's just an injection, right? Which, by the way, that injection hurts as well. That injection is terrible. But it does slightly numb the cervix. It doesn't completely numb it, but it does give you some numbing effects. Only of the cervix, not of the uterus, not of the inside of the uterus, only of the cervix, right? However, you can give stuff like lidocaine and stuff like that in a clinic setting without having to meet additional requirements for anesthesia. But if you're going to provide anesthesia, even if it's like a twilight sleep, you have to meet other certain parameters, and that's very costly. It's very expensive. It's expensive to keep a nurse anesthetist on staff. So if you're trying to do this secretly and quietly, and you're trying to provide as many as you can, you're doing it without anesthesia. And that's horrific, y'all. That is horrific. Like, this is literally torture. What Amber went through, literally torture. When you have sepsis, I have seen patients in the hospital, they don't even want the nurses to touch them because your skin hurts. Everything hurts. Think about having the flu. When you have the flu and you're like, oh my gosh, my body aches, everything aches. Like, I just don't want, that's what it's like to have sepsis multiplied by like 2, 3, 4 times. This is complete and abject torture, and there's no reason for it. There's no reason to provide this, I don't even want to say this level of care, because I don't even feel like it's care at this point.
Thank you so much for being here. Are you open to taking a few questions? I know there's so many people that would probably love to ask some questions and things like that.
Yeah.
Guys, if you do have questions and you would like to talk to Danielle, I mean, let's use our time wisely. She's here and willing to talk to us, and I think that's amazing. Okay.
And I have a hard stop at 1 o'clock, y'all, so I have a hard stop in 45 minutes.
Okay, amazing. Thank you so much, Danielle.
Hi, ladies, on this terrible day. How are you doing?
I'm doing as well as can be expected. How are you?
Awful. From, of course, the recent news and all the information provided today is exactly what I expected. But I'm so glad you're here doing that. It really needs to get out there. My question for you, Danielle, is: do you think this Louisiana case is going to be used to challenge mifepristone and SCOTUS? Are they setting it up for that? Do you think?
So I do. I definitely don't think we're done seeing mifepristone go through the Supreme Court, right? Like, we had the one case go up, and then the Supreme Court was just like, you don't even have ground to bring this case. They're not done yet. So for sure, in the background, these anti-abortion groups are definitely trying to get, we know for a fact, they're trying to get mifepristone back up to the Supreme Court. This is definitely one avenue for them to do that. The FDA technically is the one that sets those schedules. So if you look up like controlled substance, and you may already know this, but I'm also telling this for anyone in the chat, you can look up controlled substance schedule, right? And you can see all the schedules that the FDA has and how they determine what drugs go into what schedule, right? Now, the FDA has always been the one that has determined that, but the FDA has also always been the one to determine what medications are allowed to be on the market, what medications are approved to be on the market, and what's not. We have never seen the Supreme Court challenge the FDA's approval of a medication. We've also never seen the Supreme Court challenge the schedule of a medication that the FDA has set. That is now out the window because they brought that mifepristone case up to the Supreme Court. The Supreme Court agreed to look at the case and then threw the case out to say you really didn't have legal standing to bring this in the first place. But we've never even seen that. We've never seen the Supreme Court say, we know better than the FDA, and we could potentially remove access to a medication that the FDA already approved. So while on the one hand, there's really no legal precedent for this, with this Supreme Court, that does not matter. So I definitely think we're just throwing spaghetti, just like these abortion bans, right? Texas was throwing spaghetti at a wall to see what stuck. And they finally got that civil case to stick before the overturn of Roe. Remember, there was that you could sue someone for $10,000 if they got an abortion. They threw that spaghetti at the wall, that spaghetti stuck, and then we started to see that kind of being copy and pasted across the country. That's what they're doing with mifepristone as well. They're trying to see what case the Supreme Court will accept, and they're just going to keep trial and erroring it until the Supreme Court actually accepts one of their cases. This is definitely a potential avenue to do that. This avenue wouldn't remove mifepristone necessarily unless they argued it was too dangerous to be on the market in the first place. But they could definitely lobby to try to get it an increased controlled substance. And once they do, that applies to the entire country.
Exactly. I was wondering, like with Chevron deference being removed, will they now say that SCOTUS now has the ability to they can make a ruling now in the FDA because they've taken it out of the hands of the administrative state, and I wonder if they'll go that avenue and say that, which also makes me wonder how can
we're going to keep it. Hey, I'm sorry to interrupt, but Tootle, we're just going to do one question each because I just want to make sure everyone gets a chance to ask questions before.
Totally fair.
But love you. You're amazing.
Thanks.
No, sorry. I hate being the person that has to manage this, but I just have to do it so I can make sure as many people get to ask a question as possible. So just ask a question and then I'll probably drop you down and then I'll bring someone else up so we can try to get as many people through as possible.
So my question is, and I sent the Venmo asking about
Thanks. I'm glad you're here,
abortion.
Tanya.
I know that post-birth abortion is not a thing, but because Trump keeps hammering on it, I really need people to understand that it means a baby is born alive but is not going to survive. And then a parent has to make a terrible decision to not give any kind of medical treatment, but just to hold that baby until it passes away. And that's what he's talking about. But people seem to think that 7th, 8th, and 9th month abortions are for convenience. And I'm just kind of wondering how we get the point across that no, that isn't why people choose an abortion that late in their pregnancy. It is because the baby is, in a lot of cases, an abortion in the 8th month is actually a baby being born alive, but that it isn't compatible with life. And I'm just wondering how we get that point across to folks, because it's a horrible, terrible thing a parent has to do. So you can drop me. That was my.
So it's kind of it's a tough thing because I do think that there are some people that are willfully ignorant. Right? Willfully ignorant, meaning like, I don't want to know and I'm committed to this belief and nothing you tell me is going to convince me otherwise. So one thing that I always ask people is like, do you know where that comes from? Do you know what that talking point, do you know where that originated? Do you know where it comes from? And often people don't know where it comes from. So it comes from Governor I can't remember his first name, Ralph, Roger, I don't know. It's a basic man. Yeah. It's probably like Matt or something. I don't know. But I think it was Ralph or Roger, something like that. Starts with an R. So Governor Northam in Virginia, he is not the governor anymore, but he made comments in 2019 during a radio interview. You can find this radio interview on YouTube. You can easily Google Governor Northam radio interview abortion and it will pop right up. So you can bring up that interview and you can show people, you can be like, these are the comments that were made. This is where Trump is getting this from. It stems directly from this 2019 interview. And you're absolutely right. What he's talking about in that interview, and that's what I always tell people, go back to the source. Go back to the source. This is the source that Trump is using. It's that radio interview. And in the interview, he says something like, the interviewer asks, what about abortion in the 8th or 9th month? And he says, that's not happening. That's just not true. It's not happening. But what would happen in those cases? What would happen is that baby would be delivered, that person would give birth, and after that baby's delivered, the parents would then decide what to do. And the way that Republicans took that is that parent would decide whether or not to unalive that fetus. That is
Right.
not what he was saying. He's saying what the parents, and I know that you know this, but just for anyone in the comments, in case you want to have a conversation this frickin' holiday with your family, what he's actually saying is you get to decide whether or not to provide palliative care or hospice care, and you get to decide what care is given to that infant, right? So if it's already born, knowing that it's not going to survive, we already know there's no chance for survival. The parents get to decide what the next steps of treatment is for that fetus. That's what he was saying. And the other thing that I tell people, if I'm sitting here and I'm having a conversation with them, they're like, no. Like Montana, you can have an abortion at 9 months. Great. Call and make the appointment. Call right now, right here in front of me. Call and make the appointment. Call them. Call them and tell them that you're 38 weeks pregnant and you want to have an abortion. Put it on speakerphone. Call them, because they're not going to do it. They're not going to do it. So I always call people out. I'm like, do it. Call right now. Tell them that you're pregnant. Tell them that you don't have a fetal anomaly. Tell them that you just couldn't get access to abortion before now. Or tell them that you couldn't afford it. Or tell them that you didn't know you were pregnant. People give birth all the time and they didn't know they were pregnant. I mean, that's moderately believable, right? Call them and make the appointment. They're not going to be able to make the appointment. And the other thing is, like, define abortion. Make them define abortion. Well, now it's an oxymoron, right? Because abortion is terminating a pregnancy. At the point that you're born, that's not a pregnancy anymore. You're not pregnant, are you? That pregnancy has been terminated. Once birth happens, that pregnancy has been terminated. So it's one of those talking points that, like, it just amazes me that people believe this and that they're still, like, I have minimal patience for this at this point, because this is not you. To be clear, yeah, I know we're all feeling this. I like, someone says that and tell me that y'all are just like, oh my God.
Well,
like,
having watched that happen and having a daughter who just recently, thank goodness her baby was okay, but could have had a fetal anatomy at a very late stage in her pregnancy. I feel like, gosh, I mean, even family members are like, but that's abortion. Well, I had a 34-week preemie. We had to be induced. It was an abortion. Just because she was born alive and is totally fine and 31 years old now, it doesn't change the fact that I had an abortion, because it was preterm. So
thanks so much,
thank you
Sonia.
so much.
I'm so glad you got a chance to answer your question, because I thought I was going to butcher them when you sent them. So
yeah, no, I
great day.
appreciate it. Thank you.
People also, just to say this too, people will also say, like, well, what if someone is like, 26 or 30 weeks pregnant with a very wanted pregnancy, and then, like, they get hypertension so bad, or they get like a condition that, like, affects their health, right? Puts their health at risk. What if they want an abortion? We're just going to deliver the baby. At 24 weeks, we're just going to deliver that baby and cross our fingers, send it to the NICU and hope for the best. Right? So, like, we're just going to deliver the baby.
Amen. Hey, are you there, Devo?
Yep, I'm here. Hello.
Hi.
So the question that, first of all, thank you. I've heard you talk on Jay's lives, and I've heard you more, and I always learn so much. So thank you so much for doing all of this and educating us. Question I had was with regards to a lot of the states wanting to, in some way, shape, or form, access women's medical records to see, did they have an abortion? What have they had done? Whether, they did it in their own state or went to another state. I think it's Texas is suing Oregon for somebody's records. How does that, first of all, how are they able to do that? And then how are they getting around HIPAA, or how does HIPAA play into those type of things?
So HIPAA doesn't necessarily apply if a crime was committed, right? So that's one of the things that they're going to say is that, well, we can access these medical records in order to investigate a crime. And the other thing is, if you do not define abortion as a healthcare procedure, if you don't define abortion as healthcare, if you say abortion is not and never is necessary and it is never healthcare, suddenly that's not covered under HIPAA anymore, right? Only healthcare is covered under HIPAA. And if they redefine abortion as not healthcare, then that's not covered. Those records are not covered anymore under HIPAA.
That's interesting. I didn't think about that. God. Jasmine, are you there?
Hi, Danielle. Thank you so much. You're so informative. You may have already covered this, but what about like getting abortion pills or mifepristone mailed from a, that you can get mailed to you? Is that something that's still available in all states, or I don't know anything about it really.
Yep. So you can still. I'm going to tell you to do it because I'm a chaos demon, but you can take it at your own risk, right? Most of these, I am unaware of a state law that says that we are specifically going after women. Again, that doesn't mean that they're not going to charge you for something else. As we saw with Brittany Watts, they charged her with abuse of a corpse. So this is definitely something that is possible. That's why if you do this, shush.
Right.
Shush. Do not tell anybody. You can tell, like, for example, Amber Thurman had her best friend drive her, right? Like, you better make sure that whoever you tell in order to support you is your bestie, best friend.
Yeah.
And that they are also going to shush, right? And if it's your partner or somebody like that, they could end up getting charged for aiding and abetting, depending on that, like, right? Shush. Don't even tell the medical providers when
And
you
when you go to the hospital,
Don't even tell them.
Yeah, when you go to the hospital, don't tell them that that's what you did, because you'll end up in her possibly her situation.
You cannot tell the difference between a miscarriage and someone that initiated their abortion with abortion pills unless when you get, I actually have it. Hold on. Because
Everyone listen up and tell your friends tell 10 people you care about.
10 tell people you. So I don't think I have the actual, do I? Yeah, I do have an actual medication guide. I'm not going to show too much of it because I'm afraid we'll get kicked. But they send you a medication guide. They tell you how to take it. They tell you how to put it in your mouth. In the medication guide, it tells you that you can put it in between your cheeks or your gums, or you can do it vaginally. You can put the pills inside the vagina. If you are in a state that bans abortion, I do not recommend that you do that. Because if you go in for a pelvic exam, not always, but maybe, little pieces of the pill that have not absorbed or dissolved yet might be visible on a pelvic exam. They might be visible on a pelvic exam. So if you're in a state that bans abortion or you're trying to keep it secret, put them in between, you're supposed to put them in between your cheeks and your gums, and then you wait for them to dissolve, right? Usually it's 4 pills. Sometimes you have to take a second dose of 4 pills depending on how far along you are. But they're going to give you that guidance when you order the pills. Can you order pills online? Yes. So you can order them from Plan C. That's one place. Hey Jane is another place that you can get them. Honeybee Health is another place that you can get them. They usually cost about $150. I have ordered them myself, and I have an entire video on my page on TikTok that tells you exactly what happened and how I got it, right? So I say at this time I ordered the pills on this day. At this time I got an email back from the company saying this. At this time I emailed the company back my information. And I walk you through step by step with timestamps when I ordered it, when I had communication, and when I actually received the pills, right? So that way people have an idea of what this looks like and how long it's going to take and what information you're going to have to email back to these people. Now, are you emailing these people, and are these emails accessible by law enforcement? Yes, they are. Yeah. But you're going to keep your mouth shut. You're not going to tell anybody.
Yeah.
You're going to, if you have complications, you're going to go to the hospital and be like, I started bleeding. I think I'm having a miscarriage. I'm not sure.
And do you think states are going to start moving towards banning abortion pills as well by mail?
So they already have, right? Mm-hmm. A lot of them already have. Some of them have already said, like, you can't do this. You can't mail this. We also have the Comstock Act. So if we bring the Comstock Act back, the Comstock Act never went away. It's been chipped away at bit by bit. And there's pieces of it that have kind of like been thrown out or whatever, but it is still on the books. And what the Comstock Act says is that you cannot mail anything that has to do with preventing pregnancy, contraception, or abortion. So that means that not only will abortion pills not be available by mail, but neither will your birth control. So if anybody gets birth control by mail, which if you live in a rural area, that's 2 hours away from the nearest OBGYN, that's a good option for you. But they're not going to allow that to happen anymore either. So yes, you can still order them online. I am unaware of any state that is prosecuting the person who actually takes the pills. That being said, shushies.
Yeah, and it's like what, like almost between 60 and 70% of abortions are through abortion pills, right? And
Correct.
that's why we need to watch out what happens with the Comstock Act, because if the conservatives in this country can stop the abortion pill from being sent out through the mail, think of how many women have no options any longer for healthcare.
Yep.
It is the last and final frontier. And that's why you see conservatives worrying less about a federal abortion ban, right? Because will they ever get 60 votes in the Senate? That's very hard. But can, through executive power that is being consolidated in the executive branch, can they do something about the Comstock Act and stop the mailing of obscene materials? Please know that's what the Comstock Act was about. It was about sending like pornography through the mail. And now we're considering women's health care obscene.
And if anyone looks up, like, look up the history of the Comstock Act, look up Comstock. Comstock is named after a person. That guy was freaking nuts, y'all.
He was a weirdo.
Freaking nuts. He's a weirdo.
Oh, there we go. Hi.
Hi.
Thank you guys so much for all the information. I am really enjoying this learning. I just had a question about when Roe fell. Does that not affect HIPAA since it's about privacy?
Can you be more specific with, like, tell me about, like, reword the question maybe. Like, does Roe affect HIPAA?
Since Roe was really about healthcare privacy for women, does that in turn affect our rights to HIPAA with them being able to access our information?
So in theory, it shouldn't, right? Because it was about healthcare privacy in terms of, like, you have the ability to make this medical decision. The government can't make that medical decision for you. HIPAA is about the records related to any specific medical care, right? So HIPAA is related to records. Roe was related to you actually being able to make those decisions yourself, right? Bodily autonomy. HIPAA is supposed to apply to sending your healthcare information or exposing your healthcare information, right? So, like, if Felice calls me tomorrow and she says, hey, is Jen one of your patients? I'm going to say I can neither confirm nor deny any of my patients' names, right? I cannot disclose anybody who is a patient. I can't confirm they're a patient. And if I deny they're a patient, then I've actually given you healthcare information, right? I'm telling you they're not here and you might go look somewhere else. So the answer is I can neither confirm nor deny, right? That's what HIPAA is about. It's about privacy. The issue becomes HIPAA gets a little more convoluted when we're talking about somebody that committed a crime, right? So for example, if domestic violence is at play and somebody was strangled or somebody was hit or something like that, the police can usually access those medical records. And that's not a violation of HIPAA because they're investigating a crime or there was a crime committed, right? And so if you redefine abortion as not healthcare, HIPAA only covers healthcare. So if the state says that abortion is not and never is healthcare, and we're seeing that, for example, Louisiana is one of the cases. It says, well, we don't consider it an abortion if you had a spontaneous miscarriage and now we need to remove the contents of the uterus. That's not an abortion.
Okay.
Yes, it is, right? But notice how they're redefining the word abortion. That's how they're going to get access to your medical care. That's how they're going to get access to your records, because they're going to say abortion is not healthcare and therefore it's not covered under HIPAA.
Okay. Thank you so much. I really appreciate that.
Great question. That's, God, disturbing on every level. Miss Julie. Hey, Miss Julie.
Hi, thanks for having me up. just to confirm, and I know this is parsing words, but I hear the left arguing all the time about what really is an abortion, or they specifying like a fatal abortion or saying a C-section is a histrionic abortion. What's the official line on that?
Like, what's the official definition of an abortion?
Yeah.
So medically, an abortion is the termination of a pregnancy by removing an embryo or a fetus, right? So usually it's from the uterus, but in the case, I almost said from the uterus, which is almost always true, except in cases of ectopic pregnancy. Ectopic pregnancies can technically occur anywhere. So as long as it is occurring outside the uterus, it is an ectopic pregnancy. I've had people have hepatic pregnancies, which means it's on your liver. I've had people have it on their kidneys before. So that little thing can implant anywhere. But, which by the way, if you've had a hysterectomy, you can still get pregnant. It's just going to be an ectopic pregnancy. So if you still have your ovaries.
What the fuck? What?
Yeah, that kills everybody. So,
yeah.
All right. Hold on. Where's my little guy?
Wow, that
uterus.
is pretty mind-blowing.
This is your uterus. This is your vaginal canal. This is your cervix, right? Do I have stuffed animals of these things? Yes, I do. So this is your uterus. These are your ovaries, right? These are your fallopian tubes. These aren't actually attached, right? Or sorry, this right here. This isn't actually attached. So it looks like this, right? So if you've ever seen a picture of a uterus and ovaries and everything looks like it's one solid thing and it's attached, go to Google right now, Google like ovaries and uterus, and you're going to see that it's not actually attached. There's these little finger-like projections, right? Coming out. This is space. This is space, right? There's space between your fallopian tube and your ovary. In this space is where ectopic pregnancies happen, right? Now, an ectopic pregnancy almost always implants in the fallopian tube. That is the most common ectopic pregnancy that we see. It implants in the fallopian tube. But what produces your eggs? Not your uterus, your ovaries. So if I remove the uterus, you still got eggs. The only thing you need to get pregnant is eggs plus sperm. And then it just doesn't implant in your uterus. It's going to implant somewhere else.
If you don't have the cervix, how is the sperm going to get in there?
So that's called a radical hysterectomy. So there are different types of hysterectomy. That's something important to remember. And when we remove your cervix, we essentially, this is not a nice medical term and I don't like it. You essentially have what we call a blind vagina, which means it doesn't go anywhere, right? So we remove, I know I hate it. But we remove the cervix, which is right here. Actually, I said it's here. That's not true. That's your vaginal opening. It's right here. So your cervix is up here. If we remove your cervix with it, we essentially create a cuff right here and we close this off. And then you have what we call a blind vagina. What can happen though,
a cul-de-sac, perhaps. It's a cul-de-sac.
Yeah, there you go. You got a cul-de-sac. You just got to turn right back around. Okay. So, however, what can happen is that there can be some degradation there, or it may not seal completely. So if it doesn't seal completely and sperm can get through, then you can technically have an ectopic pregnancy. However, most people who have their uterus removed do not have their cervix removed. Most people don't have their cervix removed. We still suture it shut. But if there's an anomaly that happens there, and remember, sperm is like itty bitty. If there's an anomaly that happens there and sperm can get through, the only thing you need is sperm to meet egg. If sperm meets egg after you've had a hysterectomy, she's going to implant somewhere. We're just not sure where. So that's a really important thing that we teach young doctors is if you have someone come in and they say that they've had a hysterectomy, but they still have their ovaries and they're having symptoms of an ectopic pregnancy or pregnancy, do a pregnancy check and do a scan, like a ultrasound of the abdomen to make sure that there's not an ectopic pregnancy in there. Now, sometimes patients will get upset because they'll be like, but I had a hysterectomy. You still got your ovaries. There is good reason to spare your ovaries in a hysterectomy. It's because if we take away your ovaries, you immediately go into menopause, right? And we don't want you to go into menopause too early. That can cause a lot of other health risks. So unless you have to have your ovaries removed because you have like endometriomas on them, or they're like riddled with endometriosis or cysts or something like that, we will spare your ovaries. Removing the ovaries is a different procedure. It's called an oophorectomy. But if you have a radical hysterectomy, we generally take absolutely everything out, including your cervix. And then we create like a vaginal pouch, or the cul-de-sac, if you will. And then if there's a degradation in that and sperm can get through, you can still technically get pregnant as long as you still have your ovaries. And I know that freaks everybody out. It's very rare. It's exceptionally rare. Like, hear me when I tell you that it is exceptionally rare, but it does happen.
Well, we learned something new today, everyone. Okay, Shawnee. Hello, as soon as it loads.
Hey, my mind is still kind of blown from that, and I think I have lots of questions.
Me too.
Now.
Wait, one second, Shawnee. Guys, if anyone else has a question, again, Danielle has about 18 minutes left. So if anyone else has a question, now would be the time to hop in the box if you want to. If not, we'll end with Chrissy, Foster, and Friends, and then Danielle has some extra time that she's reclaimed in the day because I started late. Thanks. Sorry, Shawnee. Go ahead.
No, that was okay. Like I said, I had my original question. Now I have another question. But my first question was in regards to the different hospitals. You were talking about like a third of the hospitals in the U.S. are part of a Baptist or Christian healthcare system of some point.
Catholic.
If we do live in a place where we have a choice, what is the best healthcare system to go to? Or if we, I'm close to Vanderbilt. I'm close to, other things. Like, I should please give me education on where I should go if I'm having a female healthcare issue and I need to actually get healthcare, because that's in Tennessee. I'm in Kentucky myself. So I'm in the South. Virginia is the closest place I know. Even please, you elaborate. I'm going to go on.
So I would look up any healthcare system that is a public healthcare system, or like Vanderbilt is private, right? But that is a research healthcare system. So places like Nebraska Medical Center in Nebraska, places like Vanderbilt, a couple places in Atlanta, like the big, we have the Research Triangle in North Carolina, right? We have like Duke, and now I'm not going to come up with any of the other ones, of course. But if you can go to a research hospital, a hospital that is not a religiously affiliated hospital, and they're heavy on like medical students and research, yes, it's going to be a pain in the butt because you're going to have medical students and residents there. However, you are a lot less likely to run into some of these like religious laws, or not even laws, like these religious policies that they have. Not saying that you're going to get care. I'm just saying that you might get care sooner, that you might not have such a delay in care, and you might be able to advocate for your care better. They're still going to be at the mercy of these abortion laws, no matter where they are, right? But you might find someone willing to break them sooner.
Hi, how is everyone?
Hi, good.
Other than a little bit traumatized. Okay, so my question is, okay, let's just put the scenario out there. What if we do get a national abortion, law that, what is it? It will be. Oh, sorry. I'm trying to think, but I'm everywhere. Will there still be places that women can go, or now it's gonna be that you're gonna have to go out of state? What's gonna happen there? Are there still gonna be doctors that are still gonna be able to help if it's national? And then something else that I want people to understand: if you do your research, if it's a national thing, it's gonna hurt our economy as well by a lot,
for sure.
And so and it's in the states that are already with the abortion laws, their economy is hurting bad right now. Imagine national. So that's another thing people need to understand. But if it's national, will there still be doctors that, or is that we're gonna have to leave the state to get that help? Will there be? Are we gonna have to go back to the back alleys with that? What's going, like, what will happen if it's national?
Yeah, we're going to go to back alley abortion. So if we get a national ban, you're not going to be able to get care anywhere in the country, anywhere in the entire country. So it doesn't matter if you're in California or if you're in Washington, it doesn't matter where you are, you're not going to be able to get that care. So you're going to have to go to Canada or Mexico or insert here, like anywhere else, right? In order to get that care. I will tell you that I've already been talking to, and I can't work with them as closely as I would like to because I'm in Florida that has a ban and I don't want to get myself in trouble. But there are already groups in Mexico working on doing healthcare, what they call like healthcare tourism, but they're trying to create package deals for people to be able to go to Mexico to get abortion. I want to say that one more time since everyone thinks the US is the greatest country in the world. People in Mexico are working to create packages for people to be able to come to Mexico to get abortion care. They're working on being able to give you like a hotel plus the procedure plus a follow-up appointment the next day if you need one. They're working on getting that into like a package thing so that way you pay like one price and a company will kind of like help get you there and everything and set up the doctor's appointment and stuff for you. Literally, Mexico is looking at the US going, we got to help them.
Sorry, you can unmute. I was trying to unmute you, but I think
Hi.
we were doing it at the same time.
Hi, Felice. Hi, Danielle. Thank you both so much. This has been so informative. And I'm just very concerned, for all women right now and wondering, I live in California, but what can I do personally to help women who are facing these scenarios?
So I think that having personal discussions with any family members, you don't gotta have a discussion with someone in Walmart, but like having discussion with our family members that are not voting for this. Remember, I think it's 11 states have abortion on the ballot this November. You're going to vote on your abortion rights. Florida is one of them. In Florida, we need to get 60% of the vote on Amendment 4 in order for it to pass. It's 50% everywhere else. 50% to pass it, and then abortion will be solidified in the state constitution. So one of the things that you can do is really encourage people in your state to vote for the solidification in your state constitution of abortion rights. That will help. That will help you in that state. And the more states that get that in there, the more people can travel to that state and also get abortion care. Like when Florida's 6-week abortion ban went into place, that caused a ripple effect throughout the country. Florida was one of the top places to come to get an abortion. We were the only place left in the South to come get one. And then our 6-week ban went into play, right? So number one, figure out if you've got an abortion ballot measure on your abortion ballot this November and talk to people about it. Talk to them about voting. And we also know that studies show us that the number one way to kind of bring people over to that side is to tell your own abortion story. You can definitely tell the stories of these people that are occurring in the media, and absolutely do. But if you have a more personal abortion story, like I just shared the one with that had to do with my sister, if you have a friend, if you have a sister, or if you yourself have access to abortion care, tell people that. Like, don't let it be stigmatized. Tell people you had an abortion. Tell them why you had one. Either you were in college and you weren't ready, or maybe you were in an abusive relationship, or maybe it was a medical anomaly, right? All abortions are valid abortions, but tell your abortion story because people are going to have a really hard time looking you in the face and saying that kind of stuff. I'm not saying they're not going to, because they absolutely will, but they're going to have a lot harder time looking someone that they know in the face and saying, I don't think you deserve that care.
And there's sites you can look up for how you can help. Like I know Chrissy was filling out postcards last night that she's going to mail off to people in another state to remind them to vote or to do these things, to remind them about abortion on the ballot in certain states. Because what Danielle's saying is so important. If we can break up the maternal desert in the South and get one state like Missouri's on the ballot, Florida, where there is care available, think how many more people we can essentially save. I love you. Stop asking. Hi.
Hi. My question is more of, in a realistic sense, because we have these maternal health deserts, and I mean, we have an obvious doctor shortage, medical care shortage as it is. What are we looking at in terms of realistically recovering from this if Kamala does codify the right to abortion? Like, let's say it all goes the way we want it to. What are we looking at in terms of realistically recovering?
So Roe had a 3-trimester framework that it worked off of, right? So Roe originally said in the first trimester, there's no limitation. And then it went second trimester, third trimester, right? So there was a 3-trimester framework. The reason that got broken down was because of Planned Parenthood v. Casey, which came about years later. And Planned Parenthood v. Casey is why we have trap laws, or targeted restrictions on abortion providers. So those trap laws were things like, you have to wait 24 to 48 hours after you have your first appointment before you can initiate the abortion. You have to have admitting rights to a hospital near you. You have to have this, you have to have that. The purpose of trap laws is not to keep people safe. The purpose of trap laws is to make abortion harder and harder to provide. So in Florida, the state health agency, which this is illegal, has created a website that is spreading misinformation saying Florida has all these laws that keep women safe. They're listing trap laws, which have been proven to actually increase risk and increase complications and increase problems, right? They don't keep people safe, and we know this. However, because we had the Dobbs decision, that overturned Casey and it overturned Roe. So I'm hoping that if we can codify abortion rights with Harris, we're going to go back to that 3-trimester framework with Roe. I would rather not really have restrictions, right? I don't even think Roe is enough. I think that we should trust people to know what to do with their body, and we should trust medical providers to provide care that is within ethics and guidelines. But if the best we can do is recertify that 3-trimester framework that we had with Roe, I'm good with that too.
Amen. Yeah. In every other case, right? This is the conservatives want small government, except for some reason when it comes to women's bodies, it becomes the only case, right, where that no longer is the truth. Hi, Sarah.
Right.
Can you hear me? I've got my headphones
remuting them. Yeah, we can hear you now.
Yeah, we can hear you.
Okay. Sometimes these headphones sound funny. Sorry. My understanding of with the medical definition of abortion is the termination of a pregnancy pre-viability regardless of gestational age. Does that make sense?
Yeah, so it still counts as an abortion post-viability, right? So the viability stage is like 24 weeks. We can still perform DNCs and stuff like that past that 24-week mark. They're not common.
They wouldn't be viable if they were past that age, but still not compatible with life, right? So you could be like 30 some weeks pregnant and know that for whatever reason you didn't discover this before, but now you know it's not going to survive.
It's still an abortion. Go ahead.
Yes, that's what I'm saying, because that's still not viable. But under what circumstances are people having abortions for viable pregnancies?
So often that is a case define viability, right? So the fetal viability point is the point at which that fetus can survive outside the womb. If that fetus takes a couple breaths and it can survive for like 2 days, 3 days, 4 days, that's still viable, right? That's still you're not going to be alive for very long, right? That fetus isn't going to live for very long, but that's still considered viable in terms of you can live outside the womb. You're not going to live long. You're not going to live much. Right. And sometimes people that have like certain fetal anomalies, they can live for like 3 years and then die. So it's hard to tell depending, it's very context dependent on the anomaly, right? But when we're talking about fetal viability, that's just purely the point at which a fetus can survive outside the womb. Now, when we say like this isn't a viable pregnancy, we're talking about the fact that like, if we're talking about like 36 weeks, for example, which at that point, you're honestly probably just going to give birth or have a stillbirth, right? But if we're talking about that point, we're usually talking about like, we're not going to live very long. This is a life-threatening anomaly kind of thing. But why are they happening past the point of 24 weeks? So
well, I'm not even thinking 24. I'm thinking like even beyond that, because of obviously the argument right now with all these weirdos.
But she's what she's saying. Hold on, 1 second, Sarah. She's just defining two separate things. Like there's two types of viability, right? Fetal viability is about bodily autonomy. When can a fetus survive without me being attached to me, right? Like that's 24 weeks. Like that's viability. And then you're talking about like fetal viability in a pregnancy is a little bit different.
So I think your question is like, if it's past the 24-week mark and they're like someone's having an elective abortion, is that the question?
So because I understand there's going to be circumstances where somebody didn't get prenatal care, or they're a child and didn't recognize that they were pregnant, or whatever the case is. We're very later on. And even those people could have a fetal anomaly. It's not just like, well, they could go ahead and give birth anyways. So who are the people? Because I just don't. I'm sorry, when people go on live and say that their C-section abortion is about to graduate from college, that's not abortion. You had a live birth.
So go ahead.
No, go ahead.
I think that and I have seen like people are saying, well, it's like the termination, so technically it's a C-section abortion. I mean, I guess if you want to consider the fact that we're removing something from the uterus, right? Like we're terminating a pregnancy from the uterus. Sure. You want to call that an abortion? I wouldn't, right? I would call that a C-section. We would call that a C-section. We have a definition for that. But as to like, why are people having past the point of viability or even like into the second trimester, right? There's not that many happening. I mean, we're talking about like 1, maybe 2 in like years and years and years. The reason that abortions generally happen in the second trimester is either because just what we said, someone was a child, they're pregnant and they didn't know they were pregnant. Someone has a severe fetal anomaly and they didn't learn it until later, or we do see lack of access being an issue. Maybe they didn't have enough money, they couldn't travel or something like that before they were able to get the abortion. So those are the main reasons that an abortion happens in the second trimester.
Thank you. And guys, she has a hard stop. We have literally 1 minute and Chrissy's been waiting the whole time. Chrissy's going to go. If you're in the box, sorry, we just have to cut it off because Danielle has a hard stop at 11. Chrissy.
Sorry, Danielle, just a quick question. I live in Florida also, and as someone with mental health conditions, it just wouldn't be feasible for me to have a child. I'm also in my late 30s. I have been denied to have a tubal ligation 3 times since I was in my mid-20s. What in a situation like someone who, like me, who lives further down in Florida. So, I mean, I'm 10 hours from the closest place that would offer anything like that. I mean, is a tubal ligation an option? And do you think that that's something that providers might be more willing to give me now that this is all happening?
I definitely see more providers willing to give tubal ligations or hysterectomies now after the overturn of Roe. There is a list online. Someone on TikTok has it, and also you can find it online. There's a list of doctors that will provide you with permanent sterilization, no questions asked. You don't have to have a child previously. You don't have to be like 40 years old. They will provide you with either a hysterectomy or a tubal ligation, no questions asked, because they believe in bodily autonomy and they believe that it is your choice. So someone's saying, right, paging Dr. Fran's page, she has the list. Child-free Reddit is where the list originally originates from. Absolutely. That's what started it. Again, women crowdsourcing resources. So that's why that list originally started, because we knew doctors wouldn't provide it for us. And then women were like, well, I'm going to do it myself, right? So there is a list of doctors out there available. So I would encourage people to look up that list. If you're being denied if you're being denied permanent sterilization, look up that list, find the doctor that is closest to you, and start working on getting that if that's what you want.
That's amazing. Danielle, thank you so much for being here. I don't think you know how much when you do these things, it means to people. Like, you are absolutely fabulous. I'm so lucky to call you a friend. And thank you for coming. Like, you make such a difference in people's lives. Like, we feel so misunderstood, undereducated. Like, we're all wandering around in the dark and looking for the light switch. And every time you come, it's just for a second of like, the clarity is so calming.
Thank you.
Yes, and I will post this on YouTube so we can all cut it up. I think we should all clip it. We should use clips of this. We should send it off to the people that we know need to see it. And yeah, I'm going to get this up on YouTube, and I'll direct you guys to it tomorrow.
And Felice and I talked about trying to maybe do something relatively regular, so that way if people still have questions, they can come back and ask. So it's something that we'll definitely work on the back end for y'all.
I have her phone number now, so she can't escape me.
Hey, we're besties now. So thanks, everyone. I have to go do clinical work, but I appreciate everyone being here, and thank you so much for all the kind words.
Bye, guys. I'll see you guys tomorrow.
Bye.